आपको लाइव कर
हाँ,
लाइव
thank you. Hello everyone, I guess I'm live. Can you see me? Can you hear me? Give me a minute to confirm if I'm live. I will start the session ahead. You have to give me a minute. Let me confirm. You can leave a message in the chat box if I'm clearly visible, audible. I guess it's working. Yes. Okay. So yes, a very good afternoon to all of you. Ready for the second round? So this is part 2 question and answer discussion of the community medicine. In the morning there was a test of 50 questions. We have discussed many questions and we are continuing the discussion. So in the first part I have discussed many topics. Actually I'm not going to discuss 50 questions. We are discussing 50 topics. Whatever question is coming, we are discussing that topic in detail. I guess you all are with me. Students are still joining. Okay, we will wait for a few seconds and we will start the session. Let everyone join and settle. So, okay, so let's continue. Okay, so this is the next question in front of you. This is community medicine question answer discussion, the test and discussion. The test is already done and now we are doing the discussion for those questions. So the first next question is in front of you. Methionine is a limiting amino acid. Is it cereals? Is it maize? Is it wheat? Or is it pulses? I guess everyone knows the answer. Very easy question. Everyone knows the answer. What is the correct answer? The correct answer is the pulses. So limiting amino acid is ultra important topic. Yesterday also I taught you the 5 type of amino acid. Essential amino acid are essential because they are required to be taken in diet. We should eat them daily in our diet because they are not synthesized in human body. That's why known as essential. Non-essential amino acids are non-essential because we don't take them in diet. It's okay because they are synthesized in the body. Body will take care of it. That's why non-essential in diet. So basically essential and non-essential are decided based on the diet, whether we require to take them in diet or do not require. So essential are essential for diet and non-essential are non-essential for diet because they are synthesized in body. Semi-essential are actually essential in children but not in adults. That's why that is semi. Semi means partial essential. Okay. Conditionally essential are actually non-essential, but they become essential if their precursors are absent. And limiting amino acid is the particular amino acid which is absent in one particular food. So that is the definition I already told you. Now you have to learn the examples of each category. Now in essential amino acid, there are 10 amino acids. The remaining one, don't learn the list. Remaining one were all of them are non-essential amino acid. Semi-essential are 2 in number. Conditionally essential are 2 in number. And limiting me, we have to learn 3 examples. So learn the examples in each category. Definition I already told you. Essential amino acid which are required in the diet, not synthesized in human body. They are 10 in number. The mnemonic is PVT, Tim Hall. I told you this also yesterday also. PVT is private. We write private like PVT. PVT, Tim Hall. This is the mnemonic. You can see P stands for phenylalanine, V stands for valine, T stands for threonine, one more T stands for tryptophan, I stands for isoleucine, M stands for methionine, H stands for histidine, A stands for arginine, and double L, leucine and lysine. Very easy. Among it, you can see I have highlighted histidine and arginine with a different color. Why I had given different color to histidine and arginine? Because actually they are essential in children but not in adults. I mean to say they are semi-essential. So from PVT Tim Hall, HA is semi-essential. Never forget. And the remaining one are purely essential. Non-essential are synthesized in the body. They are not taken in diet. So remaining all are non-essential except PVT, Tim Hall. Whatever is remaining now, they are considered as non-essential. It's alanine, arginine, aspartate, aspargine, cysteine, glutamic, glycine, ornithine, proline, serine, tyrosine. Okay. Now semi-essential are required in children, not in adults. I told you the mnemonic is HA. There are only 2, histidine and arginine. Conditionally essential are actually non-essential but become essential if their precursors is absent. So what are they? They are cysteine and tyrosine. The mnemonic is CT. You can see here is the cysteine and here is the tyrosine. Can you see they both are non-essential, but I am saying they will convert, both of them convert into essential if their precursors are absent. And the last one are the limiting amino acid. Limiting amino acid, they are absent in the particular food. So in the cereals, threonine is absent. In the pulses, methionine is absent. In the maize, tryptophan is absent. So I told you a mnemonic yesterday also. Okay. So threonine, I'm sorry. Yeah, in the cereals, T is absent. In the pulses, M is absent. And in the maize, Again T is absent. So there are two T now. So in the cereals, it's threonine which is absent. In the pulses, methionine is absent. And in the maize, tryptophan is absent. Okay, so you have to learn like that. So please learn. So this is the limiting amino acid. You can see these are cereals, these are pulses, that is dal, and this is maize. Maize is bhutta. Okay, you can see. And what is limiting in that? Please learn. Few more questions on that. What are limiting amino acids? Can you identify? Limiting amino acids in wheat. I'm asking in wheat. What is wheat? Wheat is a cereal or pulse or maize. What is wheat? What is wheat? Of course, we all know wheat is a cereal. Rice, wheat, these all are cereal. So I want you to tell me the limiting amino acid in cereals. So I told you one amino acid now. What is that? What is the missing? Threonine is missing. So threonine is present in two options. So which one would you say? Which one would you say? So along with threonine, little bit of lysine is also absent. Go with option B. Let me show you where I have written. Can you see here? This page, ultra important. I told you, yes, cereals mein threonine is missing. Absolutely right. Absolutely right, Naveed, everyone. Absolutely right. So one or more you have to learn. Mainly threonine is absent, but little bit lysine is also absent. Little bit lysine. So lysine is common. You know, here also TL, here also TL. But T is different. L is lysine. T is threonine, here T is tryptophan in maize. So cereals and maize, dono mein, in both of them, lysine is also missing. Okay, but T for cereals is threonine and T for maize is tryptophan. And in pulses, if you say methionine to hai hai, methionine is absent, we all know. But along with methionine, cysteine is also absent. So please learn. Howsoever you can learn, please learn. So I want to tell you three things: cereals, pulse, and maize. Two amino acids missing in them, the main one and the second one. So main one in cereals is threonine along with lysine. Main one in maize is tryptophan along with lysine. In pulses, the main one is methionine along with the second one is the cysteine. So how to learn? It's your choice, but you have to learn the two. Better to learn two. Now in this question they asked two, now along with the main they asked the second one also. So they are asking in cereal because threonine is present in two options, you can see. So you have to mark lysine and threonine. This is the main amino acid. This is also absent a little bit. So go with B. Got it? Say yes. Can we go to the next question? Pulse protein is deficient in which of the following amino acid? We all know pulses are deficient in methionine. That was the question right now. Can you tell me which of them are conditionally essential amino acid? What is conditionally essential? Don't get confused, huh? Conditionally essential amino acid. Conditionally essential. So basically they are non-essential, but they become essential if their precursor are absent. So yes, the correct answer is tyrosine and cysteine. So I told you to learn CT. Cysteine and tyrosine. They are non-essential, but when their precursor is absent, they convert into essential. Okay. Now, if instead of conditionally essential, I tell you semi-essential, what is your answer in the same question from the same option? Which of them are semi-essential? The semi-essential are essential in children, but not in adults. The correct answer is histidine and arginine. So please mind your question very carefully. Semi-essential, histidine, arginine. Conditionally essential, tyrosine, cysteine. You should know the definition separately and example separately. So that's all about the amino acid. Coming on the next question. The next question is in front of you. Epidemic dropsy is caused by which toxin? Can you please tell me the answer? Is it BOA, sanguinarin, alkaloid pyridoxine, or ergot? What is the correct answer? Yes. The correct answer is sanguinarin. So the question belongs to food adulteration. What is food adulteration? The milawat. Okay. So whenever any food item of cheaper in price, it is mixed with the food quantity which is costly in price. So that is known as food adulteration, right? Just for the financial benefit. So yesterday also I told you, you have to learn the 5 ultra important examples here. Okay. There is a dal known as khesri dal. It looks yellow dal. So it is mixed with arhar dal. Arhar dal we all eat. It's the yellow dal normally which we eat, but khesri dal is not a good dal. It is cheaper. That's why it is adulterated here in arhar dal. It contains a toxin. The name of the toxin is BOA. Okay, and this toxin causes a paralysis. It causes a disease known as litharism. Okay, that is the thing. The scientific name of khesri dal is Lithyrus sativus. That's why the disease is known as litharism. That is the first example. The second ultra important example you have to learn here is the oil. The name of the oil is Argemon mexicana oil. It is a yellow brown color oil which looks like mustard oil. We all eat mustard oil in pickles and food. It's a normal oil but little bit costly, you know. But argemone oil is a cheaper oil, so it is adulterated and it contains a toxin. The name of the toxin is sanguinarin, which causes epidemic dropsy. That is our question right now. So you can see the question, epidemic dropsy is caused by. Answer is sanguinarin. If I change the same question and ask you the lithyrism is caused by, what is your answer now? Lithyrism is caused by. In the same options, your answer will become BOA. You got my point? So likewise, we can change the question and answer will change. You have to learn this table, the table of the food adulteration. Epidemic dropsy, I told you, the principal active agent is the sanguinarin, which is present in the argemone oil. Argemone oil, the sanguinarin is a toxin. Now, actually what it is doing, it interferes with the oxidation of pyruvic acid. So pyruvic acid accumulates in the blood and that will cause the epidemic dropsy, in which patient have sudden onset swelling of the legs. You can see swelling of the legs. The patient have diarrhea, dyspnea, glaucoma, cardiac failure, death can occur. So that is epidemic dropsy. Okay. The next question is on infant mortality rate does not include. That was my first question also related to this. Today's first question. If you are attending my session from the first question, you may be knowing the answer. Infant mortality rate does not include postnatal, early neonatal, perinatal and late neonatal. What is the correct answer? Yes, the correct answer is the perinatal mortality. Let me tell you the age-wise distribution. Okay, we will see it quickly once more. Everyone here on the screen, listen. So this is the birth of a child. This is the birth of a child. Before birth, at 28 week of gestation, the weight of the fetus is 1000 gram. So either you say 28 week of gestation or you say 1000 gram fetus. The meaning is the same, because at 28 week of gestation only the weight of the fetus is 1000 gram. Please learn this. Okay, so this is the first period. I'm dividing it, and after birth till 28 days. Here I told you 28 week of gestation onwards till birth. This is the first phase. This is known as late fetus phase. Late fetus phase. Okay, the second from birth till 28 days of life, this is known as neonatal phase. The first 4 weeks. Okay, neonatal phase. From 28 week onwards till the first birthday of the child, that is 1 year, it is known as post-neonatal. Post-neonatal. The neonatal period, that is birth to 28 days, divided into 2 zones, early and late. So first 7 days, birth till 7 days, this one, this is known as early neonatal, and this one is known as late neonatal. Early neonatal, late neonatal. From birth to 7 day, from 7 day to 28 day. You can see, right? And the last one you can notice here, from birth till 1 year, it is known as infant. Infancy. Infancy is known as. Okay. Now you tell me, infancy include what? Infancy include neonatal and post-neonatal. So basically inside the neonatal, infancy include early neonatal, late neonatal both. So this is the meaning of the infant. Okay, infant age. It is from birth till 1 year, right? One more thing I would like to tell, if any death is occurring in this period, listen. In this period, if any death is occurring from 28 week of gestation till birth, if any fetus is dying in this period, it is known as stillbirth. It is known as stillbirth. If any fetus is dying in this period, listen, in this period, let me show you very clearly here. In this period, okay, it is known as neonatal. It is known as neonatal mortality. This one is stillbirth. This is neonatal, which is again of 2 types: early neonatal mortality, late neonatal mortality. You can see up to here it's late neonatal. Now, if any child, neonate, child is dying in this period, it is known as post-neonatal mortality. Okay, this is neonatal, early neonatal, late neonatal, post-neonatal. And lastly, if any child is dying in this period, you can see the last one, from here till here, it is known as infant mortality. Infant. The last thing is the perinatal. What do you mean by perinatal? Thoda pehle, thoda baad mein. So a little bit before birth, a little bit after birth. So before birth we take this period, stillbirth, and after birth we take the first 7 days. So perinatal include this. You can see very clearly I have drawn what is the perinatal. This is perinatal. Perinatal is stillbirth and the early neonatal. So crystal clear concept. Say yes. Okay, so please learn that. Now tell me, infant mortality includes what else? So the question include does not include. Okay, so infancy is birth till 1 year. It includes 0 to 28 days also and 28 days till 1 year also. I mean to say it includes neonatal mortality as well as post neonatal mortality. I mean to say both neonatal it is including 0 to 7 and 7 to 28, actually 8 to 28. So it includes early neonatal, late neonatal, both mortality along with post neonatal. So three things are there in infant mortality. You can see infant mortality includes three things: early neonatal, late neonatal, post neonatal. So now one of the option is post neonatal, early neonatal, late neonatal. All these three are included, but perinatal is not included. Perinatal is what? The perinatal have two components. Number one, stillbirth, थोड़ा सा birth से पहले और थोड़ा सा birth के बाद. That is early neonatal. So it includes 28 week of gestation till birth or birth से लेके till 7 days. So this is perinatal, which is not included here. Okay. So correct answer is C. Everyone got it? Okay. Everyone got it? Thank you. Thank you so much. Thank you. Yes, it is the best indicator of IMR. Thank you so much for your compliments. Okay. Yes. So it is the best indicator. So let's go ahead. You know the formula. I have discussed all the formulas in the morning only, so I'm not discussing again. So we have revised that. The more you do the revision in various forms and various questions, now PSM is a very small subject. Most of the students tell me, ma'am, PSM is very vast. I say it is the most easiest subject of out of 19. It is very small. You know, the repetition is very much. Many times the things are repeated. You keep on revising in different ways, and it will fit in your permanent memory. Okay. Actually, that is the thing. Anyways, let's go ahead. You can see exclusive breastfeeding is up to what? Is it up to 6 weeks, 6 months, 9 months, or 1 year? What is the correct answer? Yes. Very easy question. The correct answer here is 6 months. I guess everyone knows that. Everyone knows that. Now it's time to perfect the topic breastfeeding. Many questions come from breastfeeding. So we will see all the questions together at one place. Let's start breastfeeding. What is breastfeeding? Breastfeeding is a beautiful process involving the mother and the baby. Okay, so it creates a bonding between the mother and the baby. When it should be started? It should be started within 30 minutes of normal delivery and within 4 hours of cesarean section, because during cesarean section the anesthesia is given to the mother, so the mother is out of the OT, out of the anesthesia, a little bit recovered, then we can start the breastfeeding. But in normal delivery it should be started as early as 30 minutes. Both are PYQ. So normal delivery it should be started within 30 minutes, and in CS, cesarean section, LSCS, it should be started within 4 hours. Both are PYQs, please learn it. Okay, now whenever you are hungry as well as thirsty, imagine you are hungry as well as thirsty. In front of you food is also there and water is also there. What would you like to prefer? You want to satisfy your hunger first or you want to satisfy your thirst first? I'm asking generally, what do you want? Of course, everyone wants to satisfy the thirst first. Hunger we can bear a little bit longer, but thirst, if we are thirsty now, we cannot bear it much longer, right? So in the same way, whenever the baby is starting the breastfeeding, so the first milk, the initial few ml of the breast milk which comes in the mouth of the baby is the fore milk, and later on the milk which is coming is the hind milk. So first the fore milk, the few initial ml which is coming now, it is rich in water to satisfy the thirst of the baby. It's like sweet water, like it contains sugar, it contains vitamin, a little bit protein, mineral. It is a mineral water, you can say. Sweet mineral water for the baby. So first mother offers sweet mineral water to the baby. It contains water, mineral, vitamins, sugar, little bit protein. After that the hind milk is there, which contain a lot of fat to satisfy the hunger of the baby. So basically at every time whenever the baby starts sucking the breast of the mother, the first few ml is the fore milk and after that there is hind milk. Say now. Yes, can we go ahead? Okay, so that is the thing. So fore milk and hind milk. Storage of breast milk. Breast milk can be stored? You may be thinking, ma'am, why to store the breast milk? Yes, breast milk can be stored. The first thing, sometimes the mother may be working. Now every 4 hours she has to feed the baby, but sometimes the mother may be working, she may not be available every time, or some unfortunate children don't have the mother. As soon as they are born, they lost their mother in maternal mortality due to any reason or due to any accident or something can happen. So breast milk can be stored and it can be given of one of the mother to other children also, right? Like we have blood banks now. In some metro cities like in Mumbai and all, breast milk banks are also there. Breast milk banking is there, right? So like blood banks are there. So where breast milk is available on cost, on price. So few mothers can donate that. The mothers who have extra breast milk after feeding their child, they can donate their breast milk for the babies who don't have mother. Now in COVID we have seen maternal mortality was very high and many small kids have lost their mother as soon as they are born. So what about the breastfeeding for them? So other milks can provide them. Okay, so in such situation we require to store the breast milk. Either the mother is working. Okay, so at room temperature it can be stored only for 10 hours, 8 to 10 hours. In refrigerator, I'm saying refrigerator, not freezer. There is a difference between refrigerator and freezer. Refrigerator, it is, I mean to say, at 2 to 8 degree refrigerator temperature. It is up to 24 hours. But in freezer, it is up to 3 months at minus 20 degree. So please learn, they all are your PYQs, the storage of the breast milk. The first you think understand why we have to store it. And number, you can understand the different temperatures and different timings. Say yes if you got it. Can we go ahead? Okay. Now let me tell you the next thing. Next thing is 4 signs of proper positioning. Now breastfeeding is important, but sometimes the prima mother is there. The first time she is pregnant, the first baby she delivered, she don't know how to feed the baby. Basically the positioning of the baby is ultra important. Now sometimes what happens, baby just the mother takes the baby in the lap, try to feed that. So for hours, for 15 minutes, for 30 minutes, she is taking the baby in the lap. So she is thinking the baby is sucking also. So she is thinking she is feeding the baby, the breast milk is going inside. But babies keep on sucking, baby get tired and baby gets nothing because the positioning is not proper. So this is not a good thing. The mother is giving the time, wasting the energy and doing all, but ultimately baby is getting nothing, and unless baby is getting tired on the other way around, because babies keep on sucking and getting nothing. So whenever there is a prima mother, it's the responsibility of the gynecologist or the doctor who is attending the lady that can teach the lady for the signs of the proper positioning. So first of all, hold the infant neck, body and head in a straight line. You can see head, neck and body in a straight line. It should be there. That is the first sign of proper positioning. Okay. Second, the baby's face should be towards the mother breast. You can see face to face. Okay. Hold the baby close to the body, and the proper positioning sign is that the upper lip should be, the lower lip should be everted. The tongue is protruded out. So that is the thing. You can see this is proper positioning. This is wrong positioning. Positioning is important. Now, what are the advantages of breast milk? What are the advantages of breast milk? Give me 1 minute. This noise I have to settle. There is power cut off. This inverter is making sound and irritating me. Give me 1 minute. I guess it's fixed. Okay, can we proceed? Okay, so what are the advantages of breastfeeding? Breastfeeding is benefited to the neonate also, and it is beneficial for the mother also. How it is beneficial to the neonate? It prevents childhood illness like diarrhea and pneumonia because it contains antibodies. Okay, it contains IgG as well as IgA. There are 5 types of antibodies, na? G, A, M, D, E. Out of which G and A are transferred via the breast milk. Placenta transfers only IgG, not A. But breast milk transfers both from mother to fetus, G and A. Two different questions. Placenta transfer only IgG, breast milk transfer G and A both. Okay. So that is the thing. Adolescent and adults who were breastfed whenever they were baby, they have less chances of having type 2 diabetes. Okay, the babies who are breastfed in future, they will be less chances of having diabetes. They have more IQ as compared to the babies who are not receiving the breast milk, and better dentation is there. These are the advantages for the baby. What are the advantages of the mother? In mother, there is reduced risk of breast cancer, reduced risk of ovarian cancer, reduced risk of diabetes and postpartum depression. All of them have reduced risk in the mother who is breastfeeding their baby. So it is beneficial for both. So is it always beneficial? Yes, apart from few disadvantages. So what are the disadvantages of breastfeeding? So breastfeeding do not contain vitamin B, K, D. B, K, D. Please learn. No B, no K, no D in the breast milk. And fluorine is also absent among the minerals. Among the vitamins, these 3 are absent. Among the minerals, only fluorine is absent, but calcium, iron, other minerals are present. So mineral में से fluorine नहीं है और vitamins में से B, D, K नहीं है. Okay, that you have to learn. Since vitamin K नहीं है, there is no vitamin K. So if the baby have vitamin K deficiency, the baby is not getting it from the breast milk also, the baby may have hemorrhagic disease of newborn. Okay, and because in the first 6 months baby is exclusively breastfed. Okay, so that is the thing. Now let's compare. There is a myth in the society that cow milk is better than the breast milk of the mother. Is it so? Is it so? Let's compare the cow milk and the breast milk of a mother. So in any religions, in many like societies or religions, whenever a newborn is born, instead of giving the breast milk, they offer to give the cow's milk. They have a taboo. It's not reality. They have a taboo that cow's milk is better than breast milk of the mother. It is a misconception. Okay, so let me tell you. You can see protein, fat, calcium, iron, everything is more in the cow milk as compared to breast milk. Yes, everything is more in cow milk. You compare protein, you compare fat, you compare calcium, you compare iron also. So, okay, and water is almost same. Energy is little bit also more in the cow's milk. So you will say, ma'am, everything is better in cow milk. Then why you are saying cow milk is not better? Apart from lactose, you can see only lactose is the thing, the sugar, the lactose, it is more in human milk. It is more in human milk. So although I agree the protein is more, the fat is more, the calcium is more, but it is not the cow milk is for cow's baby, that is calf, you know, and human milk for human baby. I mean, the God has given the composition that can be digested by the cow's baby digestive system. If you give such high amount of protein to human baby, they cannot digest it. They can digest this one only. So energy wise, you can see it's better, the cow milk, but the human babies cannot digest it at birth. Their digestive system is not that they can digest that. So for human babies, the best is the human milk only. But according to their digestive system, they have God has given like that only. So cow's milk is for cow's baby and human milk is for human baby. Okay, so that is the thing. But you have to compare. So for comparison, we will compare the milk of three animals, animal milk with the human milk. So buffalo milk, goat milk, cow milk and human milk. Human milk is the breast milk of the mother. Okay, so we will compare their fat, protein, carbohydrate and energy. We know we get energy from three things: carbohydrates, carbs, proteins, fats, and overall we get energy from all of them. So we will see protein wise, fat wise and energy wise the sequence is same. The sequence is same. And what is the sequence? The sequence is buffalo followed by goat followed by cow followed by human. BGCH. Please make some mnemonic. BGCH. Okay, BGCH. So buffalo followed by goat followed by cow followed by human. So fat wise also this is the sequence, protein wise also this is the sequence, energy wise also this is the sequence. But in lactose the human is coming to the top. So this human will come here. So the sequence will be HBGC. Okay, so please learn that. You got my point? Okay, can we go ahead? Okay, yes, so mnemonic I remember. भाई गोवा चलते हैं. भाई गोवा चलते हैं. Good one. Okay, yes. So yes, I forgot that mnemonic. भाई गोवा चलते हैं as the mnemonic. Okay, so there are three macronutrients which give energy: carbohydrate, protein, fat, and overall energy is given from all of them. So if you ask me the protein sequence, fat sequence, and energy sequence, I will say भाई गोवा चलते हैं. BGCH. Okay, but if you ask me carbohydrate, by carbohydrate I mean lactose. What is the sequence of lactose? So H will come in the front. First H, then BGC. भाई गोवा चलते पीछे चला जाएगा, है पहले आ जाएगा, है ना? So H will come in the front. From that last it will come in the front. So in human milk maximum is lactose. Rest all the things are maximum present in buffalo, followed by goat, followed by cow. Okay, say yes if you got it. Everyone say yes if you got it. So never forget the mnemonic and please learn that. So protein wise, energy wise and fat wise, the sequence, oh it's gone. So bhai goa chalte hain, right? So this is the sequence. But for lactose, H will come in the front. So HBGC, that will be the mnemonic. Can we go ahead? Can we go ahead? Okay. So the next one, human milk is rich in carbohydrate. I told you, iron and water. You can see three things here. So human milk is rich in carbohydrate, that is lactose is more, and little bit water is more, almost same, but little bit water is more, 87 ka 88 hai, and iron is little bit more. That's it. So main is lactose. Human milk protein is cysteine and taurine that can be digested by the human babies. Okay, breastfeed week is celebrated every year in the August. Every year. Okay, so next month is the breastfeeding week. You can be finding many posts on the Insta and at many places, so you will remember me that day. So breastfeeding week is celebrated every year in the month of the August. We promote breastfeeding, okay, in that week, okay, the first week of the August. Exclusive breastfeeding for the first 6 months, we have read that. That was our question. Breastfeeding can be continued up to 2 years. For the first 6 months, it should be exclusive. From 6 months onwards, weaning started, but it can be continued till 2 years. Okay, what is colostrum? The first milk, whenever the baby is taking the first time within half hour or within 4 hours, the first milk contain high immunoglobulin content. It is thick, it is yellow, that is colostrum, ultra important for the baby. Okay, what is the mean output? How many ml of breast milk output is daily in 24 hours? So if you see 24 hours, maximum output occurs in 5 to 6 months. In 5 to 6 months, you can understand now. So this is first month, second, third, fourth, fifth, sixth, and 7 month onwards. Okay. So here we are saying exclusive breastfeeding. So baby is growing in size. So the hunger of the baby is going to be increased. So God has provided like that only. So initially in the first month, mother will have very few ml of breast milk. It go on increasing. It will be maximum at 6 months for the maximum hunger of the baby. After that also the hunger of the baby is more, but we will start the solid food, the weaning also. So after that the breast milk, the output of breast milk, it will reduce. So maximum output is at 6 months. So 5 to 6 months is the maximum output. Please learn that. Okay. Can we go ahead? The next question is in front of you. That was regarding the breastfeeding. Many questions we have covered. As compared to cow milk, breast milk contains more. Few more questions of the breastfeeding. As compared to the cow milk, breast milk have only one thing extra, more. Is it energy? Is it fat? Is it lactose? Is it protein? I told you the sequence, na? Yes, you all are right. The correct answer is C. So only lactose is more in human milk. Rest all things are more in cow milk, buffalo milk, goat milk. So instead of cow milk, if I say buffalo or goat also, answer is same. Okay. The next question, in normal delivery, breastfeeding should be started within half hour, 1 hour, 4 hour or 6 hour. I am asking in normal delivery. What is the correct answer? What is the correct answer here? Yes. Within normal delivery, it should be started. Okay, 1 hour. So if half hour, according to me, someone was asking this also, no? So according to me, if half hour is given in the option, go with half hour. If half hour is not given, go with 1 hour. Or is as soon as possible is given, go with that. So sequence should be as soon as possible, followed by half hour, followed by 1 hour. So here, if half hour is given, I will go with A, not with B. Okay, so A is the correct answer here. If it is not given, I will go with the 1 hour. Okay, so that is the thing. So coming on the next question, registration of birth should be done within how many days? Within 15 days, 21 days, after 21 days, before 21 days, or within 30 days? Registration of birth. You may be knowing, no? The birth has to be registered. All birth, all death, all marriages has to be registered. So we get a birth certificate, death certificate, marriage certificate. It has to be certified. It has to be certified. Okay. So birth has to be registered within how many days? If I change the question, death has to be registered within how many days? If I change the question, marriage has to be registered within how many days? What are the correct question? And I mean, with every question, what is the correct answer? So let me tell you, I will come on the question again. Let me tell you, civil registration system. So according to the civil registration system, there is an act which was passed in 1969, long ago. It is known as Birth and Death Registration Act. Birth and Death Registration Act. According to this act, all birth must be registered within 21 days. All death must be registered within 21 days. So birth and death both must be registered within 21 days. If not done, then what will happen? The penalty is there. Financial penalty is there. Okay. And marriages के लिए अलग-अलग rule हैं. But it should be in India within 30 days. It should be registered within 30 days. Okay. So marriages must be registered. It is variable, but at most of the places it is within 30 days. After that, it's also possible, but with penalty. Okay. These are the new guidelines. Please don't learn the old guidelines. In the old guidelines, the birth was within 14 days and death was within 7 days. No, don't follow that. I mean, don't follow that. You have to follow the new guidelines. Both are 21. So birth within 21 days, death within 21 days, and marriage within 30 days. Okay, so please learn them, the new guidelines. This is known as Civil Registration System, CRS. Okay, under the Birth and Death Registration Act 1969. So there is a website on which you have to register, in which you will write the details of the baby, and within 21 days maybe the normal name of the baby is done, na? So within 21 days the name of the baby, kuch na kuch naam rakh doge. So that name has to be registered, ki there is a boy baby or girl baby, and that has to be done. So there is a website of this name, you can see. In case of delay, so after 21 days, if you want to register birth or death, both, if after 21 days, if you want to register till 30 days, there is a late fee. Late fee is only 5 rupees. Okay, so 5 rupees is there, but yeah, late fee is there. From 30 days till 1 year, along with the late fee, written permission from the district magistrate is required. And after 1 year, along with the late fee, order from the execute magistrate is required. So you have to make a notary on which you will take the order and then it will be registered. So along with the application, you have to present the notary also in which you have taken the permission from the district registrar or executive registrar. You got my point? So it has to be registered within 21 days, birth and death both. Within 21 days, if you are unable to do so due to some reason, maybe whatever. So 21 days to 30 days, what is the procedure? And 30 days onwards, 30 days to 1 year, what is the procedure? And after 1 year, what is the procedure? So learn that. So from 21 to 30 days, there is late fee. 30 days to 1 year, late fee plus permission from the district registrar. And after 1 year, late fee plus permission from the executive magistrate. So please learn that. Can we go ahead? Yes? Okay. Yes, so 21 days are there for both of them. The next question, the next topic, most common cause of LBW. What is the full form of LBW? Low birth weight in India. The most common cause of low birth weight in India is what? Is it short gestational age? Is it intrauterine growth retardation? Is it maternal diabetes mellitus? Or is it genetic cause? What is the correct answer? Can you please tell me what is the correct answer, please? Yes? Yes, the correct answer is the intrauterine growth retardation. Let me tell you everything about LBW. Very important topic and little bit difficult to understand. What is low birth weight? So the low birth weight, any baby in India who is born less than 2.5 kg, the cutoff is 2.5 kg. If any baby birth weight is less than birth weight, as soon as the baby is born, at that time, what is the birth weight? As soon as the baby is born. So birth weight is less than 2.5 kg, that baby is known as LBW baby, right? Now there is a general statement, like एक information है, the women who smoke during pregnancy, their babies are 170 gram less as compared to normal pregnancy, the female who don't smoke as compared to that. So smoking reduces the birth weight of the baby. So during pregnancy, the female should not smoke. Okay, now this is LBW baby. The birth weight is less than 2.5 kg. These are at high risk of developing infections and all because they are low birth weight. Their subcutaneous fat is less. They are high probability they can have hypothermia, infections. Okay, so low birth weight baby are less than 2.5 kg. Now coming on the cause. What is the cause? What is the cause? Okay, see the formula. Low birth weight baby, all the babies who are born and from them, how many of them are LBW? Less than 2.5 kg into 100. Okay, in world the prevalence is 14. Out of 100 babies born, 14 are this. In India it's 18. Out of the 100 babies born, 18 are LBW, right? 18 are LBW. Now there are two types of LBW. Two causes of LBW. Two types, two causes, whatever you say. So what is the cause? Let me explain. The two causes are preterm baby and short for date baby. Preterm and short for date. Short for date is also known as intrauterine growth retardation. Preterm and short for date. Okay, let me draw two uterus. It's difficult. I will try. Let me draw the two fetus for you. These are the two uterus of the mother. You can see. This is the first. This is the second. Inside them, this is the fetus. Let me try. And this is the placenta connecting the mother and the fetus. Okay. Now, do you know a rule that as the gestational age go on increasing, 20 week, 22 week, 24 week, the weight of the baby goes on increasing. So we all know as the gestational age increases, weight is directly proportional, weight also go on increasing, right? But when the gestational age is 36 week, 36 to 40 week, it's the time of the normal delivery. At that time, birth weight should be normal. The normal birth weight should be there. So baby should be normal birth weight, right? So with the gestational age, weight go on increasing, we know that. Now the first cause of LBW is preterm. It is preterm. Okay, so here the babies come out before term. What is the term? Term is 36 week. After 36 week, it should be delivered either by vaginal delivery or by cesarean section. It should be delivered after 36. 36 is the maturity. Now the complete maturity is attained at 36 week. So between 36 week to 40 week, the baby should be delivered. We wait for normal labor. If it is the labor is not there, we can induce it. Otherwise, we can do the cesarean. We all know that. So at 36 week, the weight is maximum normal. Okay. And if the baby is coming preterm out due to any reason, the preterm delivery is taking place, so weight will be less, weight will be less, but it will be proportional to that gestational age. If the baby is taking birth at 30 week, so of course it is not normal birth weight. it is LBW. But at 30 week पे जो weight होना चाहिए at this gestational age, whatever weight should be there, the baby is of that weight. So it is known as preterm. The term is, it is preterm, like term से पहले आ गया the baby. That's why this is the reason the baby is LBW. So what is the reason of LBW here? The baby is preterm, but the baby weight is corresponding with the gestational age. That is the point, right? The second possibility is that the baby, the fetus, I mean, I should not say baby, the fetus is there, the fetus weight is less as compared to gestational age. At particular gestational age, whatever weight the fetus have attained, the fetus have not attained that weight, right? It has not attended that weight. So just suppose the fetus is taking birth at 30 week. At 30 week, whatever weight it should attain, it is less than that. So here, if it is taking birth at 36 week also, it will not gain the weight which should be normal 36 week baby should have. Okay, so the reason is intrauterine growth retardation. Split the term. Intrauterine, uterus के अंदर growth retardation हो रहा है. Maybe the placenta the cause, maybe some hypertension is there, the baby is not getting the proper nutrition, maybe resistance is there, whatever is the reason. This is IUGR. So here the cause of LBW is IUGR. It is known as wait. This IUGR is known as short for gestational. Now read the term, short for gestational. So for that particular gestational age, the baby is short. That is known as SFG, short for gestational age baby, also known as IUGR baby. You got the point? Now both these babies are born, both of them are less than 2.5 kg, but the reason is different. Listen, the reason is different. Both these babies are born, both are less than, this is also less than 2.5 kg, this is also less than 2.5 kg. So technically both of them are LBW. I agree, both of them are LBW. But this one is corresponding to the gestational age. Here the weight is corresponding to the gestational age, and here the weight is not corresponding with the gestational age, right? It is less than the gestational age. You got my point? So how does it matter? You will say, ma'am, ab ye ho ya ye ho, baby to less than 2.5 kg hai. So it is LBW now. How does it matter? Okay, two things. Number one, which is more common? LBW की causes दोनों हैं. Which is more common? The more common is preterm. And second most common is IUGR. Either you say IUGR or either you say short for gestational age, one and the same thing, SFG. So most common is preterm, second most common is IUGR. पहली बात है ना. दूसरी बात, after birth, the catch-up growth, which is better in them. Both babies are less than 2.5. We want them to attain the 2.8 kg and to grow 3 kg as soon as possible, so that the chances of infection and all the things reduce in them. So who will do a catch-up very fast? So the preterm will do catch-up very fast. Okay, it was according to the gestational age, na? So after coming out, you feed them properly and all, you give them the breast milk and all, so they will gain the catch-up growth very fast. But what will happen to this IUGR? Since they are IUGR, intrauterine growth retarded and short for gestational age, they will also grow but little bit slower. Catch-up will be slower. So catch-up, this is known as catch-up growth. So catch-up growth is differing in the both. So this you will read in this pediatrics also, and I guess obstetrics also. Okay, so I tried my best to explain you. Give me a thumbs up, you got it? Okay, so that is the two types of LBW. So tell me, what are the two types of LBW, please? Number one, preterm. Number two, short for gestational age, also known as IUGR. Which is more common? Preterm is more common. SFG is second most common. Now have a look on your question. What is the most common cause they are asking? Most common cause of LBW. So what do you say answer? We will say the answer. Okay, now none of the answer is very correct. Short for gestational age and intrauterine growth retardation तो दोनों एक ही बात होते हैं. Short for gestational age and intrauterine growth retardation दोनों का मतलब एक ही है. One of the options should be premature, and that is the answer. Prematurity is not given to your options. So one of the options should be premature. Preterm. Yeah, premature means preterm. So one of the options should be premature. Here both the options are same actually to you. So either A and B both are correct. The question is wrong actually. So A and B here both are correct because the meaning of both of them is same. Okay, got it? So I tried hard. These are the two types of LBW. So LBW are of two types. The same thing is explained to you. What are preterm? These are the babies who are born before 37 week of gestation. Okay, so they are born too early. That is the problem. That is preterm, premature, preterm. They are born too early. उनको बाहर आने की बहुत जल्दी है ना? So they are born too early. Intrauterine growth is normal. It is in corresponding with the gestational age. Okay, so height, weight, length, development, everything is in corresponding with that particular gestational age. The only problem is that they came out before 37, but catch-up growth is very fast. It's good. They will catch up very soon, very fast, no problem, and they will be equivalent to their peer group. है ना? Within few days, they will be equivalent to their peer group. Okay, but short for date babies or IUGR babies, they are maybe at term, they be at preterm, maybe ये तो term पे ही born है, they are born at 37 weeks only, ये तो term पे born है, फिर भी their weight is not normal, फिर भी their वो वाले preterm है इसलिए weight नहीं, ये वाले तो term पे भी होंगे ना तो weight normal नहीं है, their weight is 10 percentile lower as that to the gestational age they should have, at that gestational age whatever weight they should attain, their weight is 10 percentile lower than that, it is not normal, okay, and they are known as IUGR, okay, that's why known as short for date baby, short for that particular date, okay, so they are smaller and lighter than what they are expected at that gestational age, right? So that is the thing, that is the thing, so that is about the things. You got my point? Say yes if you got it. So here Ketchup is little bit slower and they are not equivalent to their peer groups, वो उनसे थोड़ा सा पीछे चलते हैं 2-4 महीने, okay, but sooner or later at few years they completely catch up, okay. So coming on the next question. Okay, coming on the next question. As per WHO, low birth weight is defined as, we know the question, we know the answer. Is it birth weight less than 2.5? Is it birth weight less than 10 percentile? Is it gestational age less than 34? Is the gestational age less than 28? What is the correct definition of LBW? Yes. Okay, yes, the correct answer is the 2.5. Yes, very low birth weight. Low birth weight is 2.5. What is very low birth weight? So very low birth weight is 1.5. So there are two types, LBW and VLBW. Okay, LBW is less than 2.5 kg, VLBW is less than 1.5 kg. Okay, the next question is in front of you. How much additional calories are required in a pregnant lady? I told you this yesterday also. Additional calorie. पहले normal lady का बताओ, non-pregnant calories, and then tell me additional in the during pregnancy. Is it 350, 550, 650 or 520? What is the correct answer? Yes, what is the correct answer? Yes, you all are right. The correct answer here is 350, not 550. The correct answer is 350. Why many of you are saying 550? You are getting confused. You are confused with lactation. So I'm asking during pregnancy. I'm not asking during lactation. So please learn the calorie requirement. Calorie requirement depends which type of person you are. What is your activity daily? Are you a sedentary worker? Are you a moderate worker? Are you an intense worker? You can understand looking at the image. Sedentary means complete day sitting. Moderate means doing a little bit physical activity. And intense means running, jogging, doing a lot of physical activity. So first decide your category. Are you sedentary, moderate or intense? First decide it. Okay. Then you may be knowing. Okay. So it depends on the male or female. The gender wise it differs. And the sedentary, moderate, heavy, it also differs depending on what type of physical activity you do daily. Now this you have to learn. So let's start with the male, the sedentary male. The daily 24-hour calorie requirement in kilocalories, it's 2100. It's 2100 for sedentary male. Please learn. 2100, 2700, 3400. 21, 27, 34. In female, it's 1600. This 21 will become 21 here. This 27 will become 27 here. I mean to say the sedentary male is equivalent to moderate female. And the moderate male equivalent to intense female. So you can learn like that. Now you will not forget. So learn here 1600 and learn here 3400. You can make it out. During pregnancy, if this was for non-pregnant female, this is pregnant female, this is lactating female. Females are of 3 types. Okay, so pregnant female, whatever category she belong to, if a sedentary female become pregnant, 1600 plus 350. If a moderate worker, moderate person, female become pregnant, 2100 plus 350. And if an intense worker female become pregnant, 2700 plus 350. So it is plus 350 means additional, whatever category she belong to. And during lactation, for the first 6 months it differs, for the next 6 months it differs. During pregnancy, first, second, third trimester, it's same. Don't get confused. Please mind it. For lactation, for the first 6 months, it's additional 600. And for the next 6 months, it's additional 520. Okay, got it? So yeah, I know I have already told you this yesterday, but many students are new also, na? So please learn that. Right, the protein requirement, this is the energy requirement I told you. Energy requirement depend whether the female is or the person is sedentary, moderate or heavy. Protein requirement doesn't depend on that. It depends only on the gender, male, female. Now whether sedentary, whether moderate, whether intense doesn't matter. Whatever it is, if a adult male is there, कोई भी हो, वो sedentary हो, moderate हो या intense हो, उसको 54 ग्राम पर डे चाहिए प्रोटीन. जो भी फीमेल हो, सेडेंट्री हो, मॉडरेट हो, इंटेंस हो, उसको 46 ग्राम चाहिए. सो 54 and 46, दैट इज फॉर प्रोटीन. आई एम टेलिंग यू ग्राम पर डे. gram per day. During pregnancy, it differs trimester wise. In the first trimester, no additional protein is required. So during the first trimester, it's 46 only. It's 46 only for the female during first trimester of pregnancy. Second trimester, 46 plus 9.5, whatever is the answer. And during third trimester, 46 plus 22, whatever is the answer. So learn the additional, plus 9.5 plus 22. Okay, and during lactation, the first 6 months, the next 6 months. The first 6 months is 17, additional 17. So 46 plus 17, jitna bhi aaya answer. Or 46 plus 13, jitna bhi aaya. You can get it. Organogenesis. Maximum organogenesis takes place in third trimester. So fetus is forming inside the uterus of the mother. So at the third trimester, she requires additional protein abundantly. That's why plus 22 over 46. During the second trimester also she requires additional. But during first trimester, organogenesis doesn't take place. That is the reason. During first 6 months of lactation, the baby is on exclusive breast milk. That's why we have to give abundant of protein, that is 17. After the 6 months, the weaning is started. So this is the complete thing. Okay. Can we go ahead? Can we go ahead? So on one page, the master table we will make for both energy, protein, male, female. See how I'm drawing everyone here on the screen. Energy, protein, both we will compact in the same table. Okay. So first decide the 4 category: male, female who is non-pregnant, female who is pregnant, and female who is lactating. I request you to take your notebooks and make it with me once for all. The energy and protein, the new ICMR guidelines, the NIN guidelines. These are the new 2020 guidelines, not the old one. Don't learn the old one. Please beware. Okay. Here you have to tell me first energy requirement, energy, and then you have to tell me protein requirement. But energy requirement depends on whether the person is sedentary worker, moderate worker, or intense worker. Protein requirement doesn't depend on that. Whatever worker you are, whatever person you are, worker se mera matlab hai, whatever person you are, doesn't matter. So protein requirement is same. Okay, let's start it. Let's start with sedentary male, the energy requirement. One more thing, energy requirement is in kilocalories per day, per 24 hour. And protein requirement is grams per day. Okay, grams per 24 hour. Okay, every minute thing you have to take care of. Let's start with the male. What was the male? Sedentary male, 2100. 2700, 3400, है ना? Learn the first 2 digit. I don't learn the other 2 digit. It's beyond my limits, you know. So you can learn if you can do so. It's good. But if you can't learn, it's okay to learn 21, 27, 34, 100, 100, 100. Okay, because in your options, they will not much confuse you. Okay, anyways. In the female, you have to learn here it's 1600. Here 2100 will come here and 2700 will come here. I mean to say the moderate male is like, sedentary male is like moderate female, moderate male is like is intense female. So you have to learn like that, right? So we are done with male and the non-pregnant female, right? Male and non-pregnant female. For the pregnant female, so whatever female she is in all trimester of pregnancy, first, second, third, additional 350 kilocalories, right? During lactation, it differs in the first 6 months and it differs in 6 months onwards, first 6 months and 6 months onwards. During the first 6 months, whatever female she is, additional, how much? Additional 600. And here, additional 520. You got it. So you have to add the 600, 520 and 350 in these figures. So sometime in your exam, in your option, you will not get 350, 600 and 520. You will get the added version. You know 1600 plus 350 kitna hota hai, jo bhi answer hota hai. You will get that in the option. So don't search 350 ka hai, ma'am ne to 350 bataya tha. Mind this plus sign. It is plus. You have to add here. Whatever. Now female are of 3 types, na? Sedentary, moderate and severe, intense. Whatever, all females can become pregnant. Whatever category female becoming pregnant, you have to add in that category. That is the thing. Now coming on protein requirement, we are done here. Let's come on the protein requirement. Protein requirement doesn't depend on the activity. Okay, in all male, it's 54 gram per day. In all female, it's 46 gram per day. Okay? During pregnancy, the first, second, third trimester differs. It matters. The first trimester, second trimester, third trimester. And during lactation, the first 6 months and 6 months onwards. Okay. So during first trimester, you have to add nothing. 46 ka 46 ye, plus 0. Okay. During second trimester, you have to add 9.5. 46 plus 9.5. And during the third trimester, when maximum organogenesis is taking place, much requirement of protein, so it's plus 22 grams. 46 plus 22, whatever is the answer. Don't learn the addition because you will forget many figures. Whatever you are extra adding, learn that in the exam on the spot you can do the definition कि भाई 46 plus 22 कितना होता है, अभी से मत लर्न करो, एग्जाम में कर लेना, आता है ना मैक्स, 46 में 22 जोड़ो, जितना भी होता है whatever, you look for the options, okay, but 46 plus 22, okay, please learn that, क्योंकि you can get a question on additional as well as sum, okay, you can do both here. In the first 6 months of the lactation, it is plus how much it is, can you please tell me? During the first 6 months of lactation and second 6 months of lactation, what is the correct answer? Is it 19 and 17? Is it 19 and 17? Is it 17 and what? So first 6 months and later, so 17 and 13. So plus 13 and plus 17 and plus 13. Am I right? So please learn it thoroughly. Please learn it. So 46 plus 17, whatever is the answer. 46 plus 13, whatever is the answer. Please learn, these are the new guidelines. In some books, still old guidelines are given. Please don't go through that. This is complete energy and protein requirement, and believe me, you get many questions on that. Read the category. They are asking male, non-pregnant adult female, pregnant adult female, or lactating female. They are asking for energy or they are asking for protein. They can confuse you trimester wise, they can confuse you lactation wise, they can confuse you multiple ways. So that's all about it. Everyone give me a thumbs up that you got it. Please make it in your notebooks. Now I'm flipping it, but please make it. Okay, so that is the thing. Coming on the next question. Now you want to see the question again? Many students were wrong here. Now see how much additional calories are required in a pregnant lady. They didn't mention whether the lady is sedentary or moderate or intense worker, but doesn't matter. They are asking the additional calories. How much additional calories is required during pregnancy, and it doesn't depend on trimester wise. It is always 350. It is always 350. Got it? Give me a thumbs up. Can we go to the next question? The next question is in front of you. IQ of 55 falls in which category of mental retardation? These all are mental retardation. So if someone is having IQ of 55, is it profound mental retardation, mild mental retardation, moderate mental retardation, or idiot? What do you call that person? I'm asking the next question. Can you please try? Meanwhile you try, can I have a glass of water please? Thank you. So what's the correct answer? Can you please tell me what is the correct answer? Yes, you all are right. The correct answer is mild mental retardation. It's time to read IQ completely. All about IQ. What is the full form of IQ? What is IQ? What is the full form of IQ, and what is your IQ? So the full form of IQ is intelligence coefficient. IQ, intelligence coefficient. Let's study intelligence coefficient completely. Okay, intelligence coefficient, it's a, you can see it's a ratio. The numerator, it is calculated in percentage. I mean to say it's a proportion. The numerator is the mental age and the denominator is the chronological age. What is your chronological age? Your actual age. How many years, how many years old you are? You're 20 year, 21 year, 25 year, 30 year, whatever. Your chronological age is your that actual year, actual age. It is not necessary that your mental age correspond with that. Maybe your mental age is equal to your chronological age. It's good, both will cancel. Your IQ is 100%. That is normal. Most of the people have that. Someone is having mental age ahead of the chronological age, right? So I will tell you what categories they are. And someone is having mental age behind of the chronological age. They are retarded, mentally retarded. So that is the IQ. Mental age upon chronological age into 100. Now many students will ask, ma'am, we know our chronological age. How should I know what is my mental age? I don't know my mental age. Whether it is corresponding with my chronological age, whether I am ahead of it, whether I am behind of it, whether I am lagging of it, I mean. So how to calculate? For that, few tests has to be done. The test will be done by a psychiatrist. So go to a psychiatrist psychoanalysis, and they will do certain test. The test is known as turned IQ test. Based on that, they will tell you what is your mental age, right? So age wise the tests are different, and these are the standard tests. Okay, and first time the scale was discovered by Binet and Simon. That is intelligence coefficient, IQ, right? So calculate your IQ. What is normal IQ? I told you normal is 100 now. Ideally your mental age and chronological age should be same. So if they cancel each out, the answer is 100. So 100 plus 10 or minus 10, it's normal. थोड़ा बहुत ऊपर नीचे चलता है ना, थोड़ा बहुत तो चलता है, ठीक है? So what is normal? What is normal? Learn it's 100, but plus 10 minus 10 है ना? So 90 to 110. So please never forget how 90 to 110 is normal. Actually 100 is normal. You can see they will cancel each other. So actually it's 100, but थोड़ा बहुत ऊपर नीचे हुआ तो don't call the person Okay, mentally retarded or what? So call it's normal. 90 to 110 is normal. This is normal range. Once you know the normal, let me know you 3 category above normal and 5 category below normal. So there are 5 categories below normal and 3 categories above. पहले above देख लेते हैं. Okay, 110, 90 to 110 is normal. 110 to 120 is superior. 120 to 140 is very superior. And more than 140, it's near genius. There is no genius in this world. The maximum IQ is near genius. So don't call anyone genius. There is no one genius. So the maximum category, the word we can use, he's very near genius. Okay, not very genius, near genius. So that is the 3 categories: superior, very superior, and near genius. Let's go on the lower side. So in lower side, if someone IQ, so 90 to 110 is normal. If someone has someone IQ 0 to 25, very less, 0 to 25, you can call that person as idiot. Idiot is having IQ 0 to 25. Okay, 25 to 50, 25 to 50, you can call the person imbecile, imbecile. 50 to 70, you can call the person moron, whatever. Okay, 70 to 80, you can call the person borderline. And 80 to 90, low normal. Please learn the categories. Say yes. Okay, got it. So please learn this classification. This is the classification of IQ. Okay, let me tell you the classification of MR. MR is mentally retarded. Mentally retarded. Okay, so what is the classification? You can see here, we call MR at 70. At 70, although below 90 से कम पे भी नहीं बोल रहे हैं, यहाँ से लेके MR बोल रहे हैं. Up to 70 we are considering normal. More than 70 we are considering normal. Below that we are calling it MR. So for calling MR, the mentally retarded, the cutoff is 70. Above 70 we are calling normal. Below 70 is MR. Below 70 is MR. Don't get confused. Although normal range is 90 to 110, but for MR the cutoff is 70. I mean to say that. For MR the cutoff is not 90. If someone is having IQ 80, I will not call the person as mentally retarded. I will not call. The cutoff is 70. 70 से नीचे होगा तो हम बोलेंगे ये तो mental है, mentally retarded है ये person, right? So that is the thing. So below 20 is profound mentally retarded. 20 to 35, it's severe mentally retarded. 35 to 50, it's moderate mentally retarded. And 50 to 70, it's mild mentally retarded. Mild, moderate, severe, profound. These are the categories of mentally retarded. Okay. And we go ahead. Okay. So coming on the next question. So we have done everything about the IQ. Either you will get a question on this scale. Now have a look on your question. You can make it out. Have a look. An IQ of 55. So what is the category, in which range it is coming? Let me write the range. Mild mentally retarded, moderate mentally retarded, severe mentally retarded, and profound mentally retarded. So profound is less than 20, right? Less than 25. 25 to 50 is severe. Am I right? Am I doing wrong thing? I guess I'm getting confused. Less than 20. So less than 20, 20 to 35. 35 to 50, I got confused, I'm sorry. 50 to 70. In your question, they are asking 55. Where 55 is coming? 55 is coming here in this range. So that's why mild. Instead of 55, if I give you 40, it will be moderate. If I give you 25, answer will be severe. If I give you 5 or 10, answer will be profound. You can see your options, the 4 options. If I change the number, answer will change. You should know this completely. Less than 20, 20 to 35, 35 to 50, and 50 to 70. Please learn. More than 70 is normal. I mean, not normal, but it is not mentally retarded. So this is mild, moderate, severe, profound. Please learn. Please learn. Or else you can get a question on this. Who is idiot? Who is imbecile? Who is moron? Especially on these 3. Idiot, imbecile, moron. Repeatedly ask questions. Please learn it very thoroughly. What is the IQ of an idiot? What is imbecile? What is moron? Please learn. And near genius also. Please learn. Okay, so that's all about it. Coming on the next question very quickly. Let me read it. Are you people there? Can we continue? Give me a minute. The next question is in front of you. Which of the following is true regarding the incentives to the ASHA in Janani Suraksha Yojana? One of the question from National Health Programs. Janani Suraksha Yojana, you may be knowing. So we give incentive to the ASHA. Now why we are giving incentive to the ASHA? What is this program is about? Who is Janani and what is the Suraksha is about? So Janani is the pregnant lady who is going to give birth to a child. That is Janani. Janani is the going to be mother. Okay. And why we want to give Suraksha? What is Suraksha? We want to protect her. Hai na? So maternal mortality rate is very high in India as compared to other countries. What is the most common cause of maternal mortality rate? I told you the most common cause of maternal mortality rate is hemorrhage. It can be antepartum, intrapartum or postpartum. Now how we want to reduce it? We want to give Suraksha to the mothers. Hai na? We want to protect them. We do not want the pregnant lady can die during pregnancy or at the time of delivery or within 42 days of after delivery as a complication of delivery. So that is the definition of maternal mortality rate. We do not want that. So one of the way is to reduce that is institutional delivery. Yes, institutional delivery. There are two ways. Number one, all the pregnant ladies should take antenatal care. What is antenatal care? They should come to the PSC, they should visit the doctor should examine them, and they should do their hemoglobin, blood grouping, the basic test, the urine test and all. And number two, at the time of the labor, the delivery should be institutional delivery. It should not be home delivery. In villages, home deliveries are very common, which is performed by the senior lady of the of that home, of that family, I mean, or it is performed by dai. If the dai is trained dai, it's okay, but if it is an untrained dai, then it can be a problem. So if it is a completely normal healthy delivery, it's okay, but sometimes it will have a minute complication that can be managed well at the institute, cannot be managed at the home, and it results in maternal mortality. So we do not want that. So we want to promote two things. Number one, during pregnancy, antenatal visits should be there. The lady should come to the PHC, CHC sub-center, and they should get visited, examined by the doctors, healthcare providers there. Okay, and at the time of the labor, institutional delivery should be there. So we are trying to promote this, counseling the ladies, all the pregnant ladies, but you know, it's very difficult to counsel village people. Try it out. Very difficult. They have their beliefs, which is unshakable. Whatever you are counseling them, trying your best in their language, at their level of IQ, you are talking to them, but still you will be unable to do so. I have tried a lot. Okay, so sometimes it's impossible to shake their beliefs. No, they will hear you, they will understand everything, they will say yes, but they will not adopt your whatever you are saying. Okay, so what to do? We want this habit, like this thing to be adopted by them. So we launched Asha. You know, Asha is a lady. So there are criteria. What is the education? What is the salary? What is that is Asha. Now we launched a worker, that is Asha, that is among the village people only. So if we go as a healthcare provider, as a doctor, and if you talk to the village people, the ladies there, the pregnant ladies, they will not convince. But one among them, like Asha is one among them only. She is from that village only particularly. Okay, everyone knows Asha, that she is our well-wisher, right? So if she try to convince now, it will be easy for them to understand what we are saying. Okay, so instead we counsel them and convince them. Let Asha do so, and we will give incentive to the Asha for doing so. So that is the program that is Janani Suraksha Yojana, in which we will give incentive to the Asha as well as pregnant lady for doing two things: antenatal care and institutional delivery. You got it? Yes. So yes, so that is the thing. So let me tell you, it's difficult, but I will try. Okay, so Asha is a lady, local, belonging to that village only. She knows the local language, she knows the mentality of the people belonging to that village, and she knows the ways also how to convince them. So let's counsel Asha. Do not counsel the whole village, you convince Asha. Asha will convince everyone. So she is the link, you can say. Okay, so she is bridging the link between the healthcare services and the village people. So she is Asha. So this Asha will go to the pregnant lady and counsel the pregnant lady to do the antenatal visits, and at the time of the labor, do the institutional delivery. Don't do the home delivery. She will counsel. We don't have to do so. She will counsel. We have to just instruct the Asha, you have to do so, right? But Asha will, why she will do so? She will say, okay, I will do that. But she will say, okay, I have convinced everyone, but they are not counseling. We have to give incentive above the fixed salary. She is getting a fixed salary, but for every lady, the lady who is doing institutional delivery, we will give incentive to the Asha. So because of the incentive, she will be interested in extra money over the salary. Incentives are the extra money now. Then she will do that. Okay. So this is Janani Suraksha Yojana. Okay, so I have briefed you what is Janani Suraksha Yojana, why it is required, and why the government is giving. Now government is great now. So the government is giving incentive to Asha also and pregnant lady also. We have to give incentive to both. Okay, so first of all, you have to see whether you are talking about a rural area or an urban area. Rural area or urban area, in where it is more required, you tell me. In rural area, of course. In urban area, the awareness is well. Now institutional deliveries are very common in urban area, and home deliveries are less, because people are aware, they are educated. The first thing you have to see, is it rural area और अर्बन एरिया, ठीक है, नंबर 1. नंबर 2, इन ईच ऑफ द एरिया, रूरल एज वेल एज अर्बन, 2 types of states are there: low performing state, high performing state, based on the education literacy rate of that particular state. Now government has given a list that which state is low performing, which is high performing, based on various indicators like Madhya Pradesh, Uttar Pradesh, Bihar. Some of them are low performing, like Kerala, Gujarat, they are high performing, not based on the economy, based on few other indicators which are health related. Okay, so some states are low performing, some are high performing. So see rural ki urban, see low performing, see ki high performing. Based on that you will decide the package. Now let's talk about rural areas first. In rural areas, in low, now low और high में से भी किसको ज्यादा देना पड़ेगा? To whom you have to convince more? The low performing state, they are already low performing, they are uneducated, the health indices are not good. Okay, so you have to give a bigger package to attract them, है ना? In high performing, they are aware, they are educated, so even a less package will work. Okay, so in low performing states, in rural area, in low performing states, government is giving total package of 2000, out of which 600 is given to the ASHA. The remaining, what is remaining? 2000 minus 600 कितना हुआ? 1400 is given to the mother. For doing what? For doing 2 things: antenatal care and institutional delivery. वही 2 चीजें है ना. So ASHA को भी एक बार में नहीं मिलेगा 600. ASHA will be given 600 in 2 installments. This is an extra incentive above the salary, है ना. 300 for the ANC component and 300 for the institutional delivery. Okay, so that is the package of the ASHA. So out of 2000, 600 is given to the ASHA, 1400 to the mother who is performing institutional delivery, right? तो इसी लालच में मदर्स की चलो पैसे मिलेंगे, 2000 मिल जाएंगे, डिलीवरी तो करनी ही है, अब घर पे करो इससे तो हॉस्पिटल में करो, हॉस्पिटल में करेंगे तो 2000 एक्स्ट्रा मिलेगा. सो फॉर दिस बेनिफिट दे विल कम, फॉर दिस इंसेंटिव यू मस्ट से दे विल कम टू द हॉस्पिटल, एंड दैट्स व्हाट वी वांट. वी वांट अ इंस्टीट्यूशनल डिलीवरी. इन हाई परफॉर्मिंग इंस्टेड ऑफ 2000 गवर्नमेंट इज इन्वेस्टिंग ओनली 1300, लेकिन आशा पैकेज इज फिक्स, आशा का कट तो फिक्स है. सो 600 is given to आशा only. What is left after that? 700 is given to the mother. So please learn, this is the rural story. How I learn ना, I learn the total package कि 2000 और 1300, 2000 और 1300 गवर्नमेंट का टोटल पैकेज है. अब ये भी याद करने की जरूरत नहीं है कि 2000 लो परफॉर्मिंग स्टेट में है और 1300 हाई. कॉमन सेंस. 2000 is in low performing state, 1300 is high, and 600 is ASHA, always fixed. Remaining is mother. Okay, now coming on likewise urban area. In urban areas, learn the total package. Low performing, high performing. Low performing में government is giving 1400. Okay, it is less than 2000, you can see, and here government is giving only 1000. So learn 1400 and 1000. Here ASHA package is only 400. So 1400 minus 400, that's 1000 is given to mother, and 1000 minus 400, that is 600 is given to mother. Say yes if you got it. Can we try it together? It's difficult. Help me out now, please. So Janani Suraksha Yojana, right, for 2 things. We want the mother to take antenatal care, we want the mother to take institutional deliveries, for which the government is giving incentive to both the ASHA and the mother. The ASHA for convincing mother, the mother for getting convinced. Okay, so let's divide into 2 portions, rural and urban. Can we start? This is rural, this is urban. Will you help me? In each of them we will divide into two portions. We will divide into two portions: low performing state, high performing state. Here also low performing state, high performing state. Okay, so tell me three things now. What 3 things you will tell me? What is the mother package? What is ASHA package? What is total package? Here also mother package, ASHA package, total package. Okay, how I learn? Let me tell you, then you decide yours. Let's start with rural and let's start with total package. It's 2000 and what was the thing? 1400, na? It's 2000 and 1400. Am I right? 13 or 14? So it's 1300. 2000 and 1300. Okay, am I right? Okay, yes, it's 2000. Yes, and here it's 1000, and here it's 1400. Here 1413 I'm getting confused. So here it's 1300, here it's 1400. Yes, am I right? I'm right. I'm sure I'm right. Okay, so this is the thing. Now just decide the cut of the ASHA. ASHA in rural gets 600, ASHA in urban gets 400. So deduce that whatever pending, that is given to the mother. So 2000 minus 600, it's 1400. 1300 minus 600, the remaining is 700. 1400 minus 400, the remaining is 1000. and 1000 minus 400, the remaining is 600. So don't learn mother तो मैं कभी learn ही नहीं करती. On the spot we can do the deduction. और ये भी मुझे याद है कि rural में आशा get 600 600, urban में आशा get 400 the 400. I learn only total package, and it is the easiest way to learn. 2000, 1300, 1400 and 1000. So rural, urban, low performing, high performing. Give me a thumbs up. Got it? I tried hard. Janani Suraksha Yojana. Otherwise, it will be difficult to learn. Say Janani Suraksha Yojana. This is Janani Suraksha Yojana. I told you the purpose also and what the government is doing. See how the government is wisely using the money to attract the people for doing institutional delivery. Come on, react. Say something. And we go ahead. This is Janani Suraksha Yojana. Can we try the question now? Now read the question and tell me the answer. Which of the following? See, the question is very complicated. You cannot give a guess. Guess bhi diya to galat jayega. You have to know it, the exact criteria. Make this table and match now. You will get it. So what is the incentive of the mother and the Asha? So the four options are 400 to Asha and 1000 to the mother in rural area in HPS. 400 to Asha, 1000 to mother in rural area in LPS. 400,000 in urban area HPS. 400,000 in urban area LPS. Now it's very confusing. Make a table and match it. Once you make a table and match it, now you will come to know these three options are wrong. Kuch mismatch hai. This one is only right. I'm not going in detail. You just make the table and you just match it. You can see the level of the question. It's a very difficult question. The one who know the exact table, that person, that student only can answer it. Otherwise to tukkebazi to sabhi karte hain, hai na? The exact answer sahi, satic, to be specific, to be accurate and valid. You have to know it. You have to learn this table. Okay. Coming to the next question. Okay. That's all about it. Okay. So coming to the next question. The next question is in front of you. Ujjwala scheme is for. Ujjwala. I'm pronouncing it clearly because there are three schemes related to you. Okay, what is it is related? Is it drug abuser rehabilitation? Is it blind person rehabilitation? Is it online tracking of the AIDS patient, HIV patients, or is it child trafficking? Yes, what is the correct answer? The correct answer is this. So please learn the three schemes, the closely related programs which are frequently asked in your program, in your exams. Ujjwala. Please pronounce it. See the spelling and pronounce. Ujjala. In Hindi, it is written like that. Ujjala. Ujjala means light. Roshni. Light. You know, Ujjala. So, Ujjala Jyoti is looked by the Unnat Jyoti. Unnat Jyoti by affordable. It means to provide the affordable LEDs to all the village people and all the periphery. Affordable LED program. Affordable LED program. It is governed by Unnat Jyoti. It is under Domestic Efficient Light Program. Domestic Efficient Light Program, DELP. You can see. DELP, Ujjala. Affordable LED. See, the LED is smiling. It is affordable LED. So that is the diagram, है ना? That is the logo. You can see. You can understand. Ujjala. Ujjala में तो कोई confusion नहीं है. Everyone knows the Hindi Ujjala means light. What is Ujjwala? Ujjwala. So that is the free LPG connection is given to all the females who are BPL. All the females who are below poverty range, they are cooking on the, like they burn the, what do you say, wood and all, so, or the coal. So they are cooking on the coal, they are burning the wood, they are cutting the forest and trees and they are burning on that. They cannot afford LPG gas. So the free LPG cylinder gas is provided to them. So that is Ujjwala. Ujjwala. And after that, Ujjwala. It is the prevention of childhood sexual trafficking. There are many groups and so all that they are doing the childhood sexual trafficking, especially of the female girl childs, and they are transporting them to some other countries, and it is all that. So preventing that, it is Ujjwala. So please read your question very carefully what they are asking. Here Ujjwala was asked, so that's why we have ticked D. Okay, can we go ahead? Can we go ahead? Okay. So you want a break, I also want a break, a little bit break we will take. So what's the time right now? It's 4:55, I guess. Okay, so let's start at 5:15. 5:15. Okay, a break is there. Okay, so I will be back at 5:15. A small break, coffee break. Okay, so I will be back and many important more topics are there. So you people go and you people join very late. Why? So everyone be here only. It's just 15-20 minutes. We will have a small coffee and tea break, and after that we are going to continue ultra important topics. Don't go anywhere. Don't go. Don't miss any portion. Okay, thank you so much. I'm not ending the streaming. So the same key will continue. The same link will continue, I mean. And I'm just switching off my camera and mic. Thank you. Are you people there? Hello, am I back? Is someone listening me? Kindly can you confirm in the comments if I'm clearly visible, audible? Let me check. I will wait a while. Okay, I guess it's working. Thank you. Thank you for confirming. Thank you so much. Okay, just a second. Okay, so let's continue. I welcome you all and let's continue ahead. I guess everyone is refreshed, having a cup of tea, coffee. Let's continue. So the next question is in front of you. XDR means extensive drug resistance to which drug? So the question is from resistance of the TB. Maybe it is related to pharmacology, but we will see a little bit here. The pharmacology portion also and the PSM portion also. So is it minimum one of the injectable drug or all of the above? So what is the correct answer? Of course, the correct answer is D. So let me tell you everything about the resistance in TB. So you want me to teach you a little bit about the dots because I cannot teach you directly the resistance. If you don't know even the drugs of the TB, how can I tell you the resistance? So a little bit of the pharma portion is related here. So don't worry, now pharma is also your subject. So I will not cover the entire TB drugs, but a little bit about it. So let's start the anti-tubercular drugs. Okay. So there are anti-tubercular drugs. The first line drugs are 5. Everyone knows the 5 first line anti-tubercular drugs. HRZES. H is isoniazid, R is rifampicin, Z is pyrazinamide, E is ethambutol, and S is streptomycin. These are the first line drugs, HRZES. Out of them, the first HRZE are oral drugs, and the last one, streptomycin, is injectable. You know, streptomycin is aminoglycoside. Now, you may be knowing aminoglycoside. So it is one of the injectable. Now, what are the second line drugs? In second line drugs, we have fluoroquinolones. By fluoroquinolones, I mean all fluoxacins, Oflox, Levoflox, Moxiflox, Ciproflox. So 4 flox are there: Oflox, Levoflox, Moxiflox, Ciproflox. So these are the fluoroquinolones. Apart from that, injectables are there. Here we have one mycin, streptomycin, one of the injectable. Here few more mycins are there: kanamycin, amikacin, capreomycin. Kanamycin, amikacin, capreomycin. These are also aminoglycoside, so these are also injectable. So I mean to say, in the first line we have only one injectable, that is streptomycin. In the second line we have 3 more injectable: kanamycin, capreomycin, amikacin. Apart from that, other drugs are also there. Just read their names, don't learn. So that is the classification of anti-tubercular drugs. Okay, that is the classification of anti-tubercular drugs. Anyways, okay, what you are saying? 50 question. Okay, what you are saying. So it is one of the question of your test now. Anyways, so listen. So just a second. So let me tell you the management of the TB. Now, in the management of the TB is the DOTS. What is DOTS? What is the full form of the DOTS? DOTS is directly observed therapy short course. Directly observed therapy short course. It is short course. Okay, we agree that it is a therapy. But why it is known as directly observed? What do you mean by directly observed? You can see this is the logo for the DOTS. DOTS is short cure for TB. You can see there is a human being, half red and half orange. You can see this is the logo for the dots. Please learn that. Now, why it is known as directly observed? Because here we give the drugs to the patient, the anti-TB drugs. I will tell you which drugs. In intensive phase, we give drugs to the patient and we observe. One of the healthcare provider observe with his own eyes that patient is taking the drug in front of his eyes. We will not give it for home. In home, maybe the compliance is not very good. Patient is sticking to the schedule or not sticking. So we ask the patient to daily come in the hospital. We will provide the drug free of cost. And in front of our eyes, patient take the drug with water. Then it is allowed to go, right? And the next day patient comes again like that. That's why it is known as directly observed therapy short course. That is the meaning of the DOTS. Okay. That is a healthcare provider or a trained person, not necessarily doctor, can be Anganwadi worker, can be Asha, can be male health provider, female health provider, can be the school teacher of that child if it is to the child. So it watches the patient swallow each medicine in intensive phase in front of his eyes. That is the thing. That is the meaning of the DOTS. Now in DOTS there are 2 phases, intensive phase and continuation phase. How many of you understand that? Okay. What you are asking? PSM का टेस्ट था ना 50 क्वेश्चन का, वो एक आवर के लिए ही लाइव था क्या ऐप पर? यस ऑफ कोर्स इट वाज लाइव पर ऐप पर. उसके तो डिस्कशन चल रहा है. अब डिस्कशन चल रहा है तो आपका एक टेस्ट आंसर तो डिक्लेयर हो गया ना. तो द टेस्ट वाज बिफोर द डिस्कशन. टेस्ट वाज 8 to 9. 9 onwards discussion is going on till now. Okay, got it? Can we proceed? Now concentrate on the discussion. So in the DOTS there are 2 phases: intensive phase, continuation phase. What do you mean by that? What do you mean by that? DOTS, intensive phase and continuation phase. Now imagine there is a person this is a person and he is having TB. He is diagnosed with TB. He is having pulmonary TB. So he is having the TB in the lung, the pulmonary TB. Now my first priority, now this patient already had the TB. Okay, now he's coughing. Via coughing, in TB the cough is there, via droplets he's spreading to infection to multiple people in the community like COVID. Okay, so he's spreading that. Now in the intensive phase, my first priority to make him non-infective so that I can save other community people from having TB. So I want to make his sputum negative. Whether the organism inside him is 100% killed or not killed, but I want to make the sputum negative. That's why in intensive phase, I give aggressive treatment. The ultimate aim of the intensive phase, so that at the end of the intensive phase, the sputum should be negative. That is, if the sputum become negative, person will become non-communicable. It will not transmit the disease. Although disease is present inside it, but it is not transmitting to others. That is the meaning of the intensive phase. Now in continuation phase, we will continue the treatment. We will give little bit less aggressive treatment because patient is already non-communicable now, and we will make the patient cure. So here the ultimate purpose is cure, so that all the organism inside the patient are killed. Not only sputum, we want the patient free of TB. Here in intensive phase, we want to make the sputum free of TB. But in continuation phase, we want to make the patient free of TB. You got the meaning? You got the meaning? There are two phases, intensive phase and continuation phase. Okay. Now in intensive phase, we ask the patient to come to the hospital daily, right? For how many months the treatment is there? I will tell you two categories, category A, B, 1, 2, whatever. So in that, for how many months the patient have to come to the hospital daily from Monday to Saturday daily, and in front of our eyes we will give the treatment. That is under direct supervision. But in continuation phase, patient have to come once a week, every Monday, every Tuesday. We will fix one day. So every Monday, just suppose the patient is coming, the first dose is directly observed. So I will take the blister, I will take the medicine blister, I will give the first dose. The patient will take in front of me. The remaining blister I will give for home for 1 week. I will ask the patient just empty the blister, come back the next week. I will refill the new blister. First dose you have to take in front of me. That is the meaning of the continuation phase. So first understand the two phases, that is intensive phase and continuation phase. Okay, so you can see the blister is like that. Now let me tell you the two categories. So intensive phase, continuation phase. I told you what is the purpose of each of them. Intensive phase, we want to make sputum negative, and in continuation phase, we want to cure the patient negative of the TB, right? So while coughing, the patient is spreading to everyone. Now in intensive phase, make the sputum negative, and later on we make the patient negative. So there are two categories, category 1, category 2. What do you mean by that? Let me explain. There are two categories, Cat 1, Cat 2, or nowadays it is known as Cat A and Cat B. Cat 1 patients are the new patient who don't have TB previously and who have not taken DOTS in the past. So that is Cat A patient. Okay, and category B patient are the patient who are treated previously. You will say, ma'am, who are treated previously? There can be three types of patient. Either they are treated, they started the treatment and they left the treatment in between, they run away and they are coming again. Maybe village people, I was having a marriage at my home, I was having some emergency, so I went for 1-2 months and now I want to continue the treatment. Oh my god, you are Cat 1 at that time, now you are Cat 2. So this is not the way. So the sticking to the treatment is ultra important in TB. That's why we are doing it directly observed. So you consult the patient on the day 1 only that you have to stick to the treatment for next 6 months or 8 months. In Cat 1, the treatment is for 6 months. In Cat 2, the treatment is for 8 months without missing even a single day. Okay, so that is the thing. So either the patient run away and come back, that is known as defaulter, or the patient is having relapse. The patient is completely treated in the past. 2-3 years back, patient was having TB and now having again. So that is a relapse. Or the patient is having the failure. So complete treatment is done, and at the end of the treatment also patient is still positive. So we will shift it from Cat 1 to Cat 2. So these are the 3 patients of the Cat 2 who have taken the treatment in the past. So my point is that category 1, category 2. Category 1 is a new patient and category 1 is a patient who has taken the treatment in the past. Treatment in the past can be a defaulter, can be a failure, can be a relapse. The meaning of 3 I have explained you. So that means if he has taken the treatment in the past, whatever is the reason. Now the treatment for both of them is different. Each of them we will divide category 1 and category 2. For category 1, the total treatment is of 6 months, out of which the first 2 is the intensive phase and the next 4 is the continuation phase. Okay, for category 1. For first 2 months, you will give all 4 drugs together, HRZE. Combining them, making 1 tablet, not 4 different tablets. Okay, and in continuation phase you give only 2 of them, H and R, no Z, no E. Okay, you know HRZES, I guess the full form. So that is Cat 1. In Cat 2 you give total treatment for 8 months, 8, not 6. Here 6 and here 8. Out of 8, the 3 months are intensive. Remaining 5 months are continuation. In the 3 months also we divide it into 2 portions. The first 2 months and then 1 month. What is the difference? In the first 2 months we give all 5. What are all 5? HRZES. We give S also. HRZES. I told you S is injection. Daily we give 1 injection to the patient. 4 tablets, 1 injection. 4 tablets, 1. Not 4 tablets. We combine the 4 and make it 1. So 1 tablet, 1 injection. For the first 2 months, रोज एक injection लगेगा भाई, है ना? So HRZES. For the next 1 month, only HRZE, no injection. So intensive phase, and in continuation phase, only HRE. You got it? So this is the treatment. So what is the treatment? Can you please tell me what is DOTS? In DOTS, we divide the patient in 2 categories, category A, category B. Or in the old classification, it was category 1, category 2. Can you please tell me? Yes. Are you people still there, na? So category A, category B. Who are category A patient? These are the new patient who have not taken the treatment in the past. What are category B patient? These are the patient who have taken the treatment in the past. They can be defaulter, relapse or failure. You know the difference between them. Now each of them we divide into 2 portion. Here the total treatment is for 6 months. Here the total treatment for 8 months. Here we divide the 6 month like into 2 portion. Intensive phase, continuation phase. Here also we divide intensive phase, continuation phase. You know the difference. Intensive phase patient has to come daily to the hospital. All the drugs are under direct supervision. And the ultimate purpose is to make the sputum negative. And in continuation phase, only first dose is supervised. And for 1 week, we give the medicines for the home. We give the medicines for the home. Okay, I will tell you later on. Okay, so this is the continuation phase and ultimate purpose is to cure the patient. So tell me the drugs in intensive phase and continuation phase in each of them. So here intensive phase is 2 months, continuation is 4 months, that is 6 months. Here intensive is 3 months, continuation is 5 months, that is category 2. Among the 3 months also we divide into 2 portions. That is first 2 months different treatment, next 1 month different treatment in intensive phase itself. It's time to write the drugs. Will you help me to write the drugs, please? Would you like to help me? Okay. Let me try. Here we will give HRZE. Here only H and R. No injection. In Cat 1, no injection. No S. Okay. In Cat 2, category 2, the first 2 months of the intensive phase, we give all 5. HRZES. Pancho de do. The S is injectable. For the next month, 1 month injection hata do kam se kam. HRZE. है ना? Or in continuation phase, only HRE. Am I right? Okay, so this is the pharma portion, I agree. Less important in PSM, but without which I cannot explain you the resistance now. Okay, so this is the DOTS treatment I taught you. Doses you can learn in the pharma. I'm skipping. Now let's come on the question. On the question, that is drug resistance in TB. In TB, there are 2 types of drug resistance: multiple drug resistance and extensive drug resistance. That is MDR and XDR. What do you mean by that, MDR and XDR? MDR means resistance to H and R. Out of the 5, the first 2 topmost, most important drug, the patient is resistant. H and R, the patient is not responding to that. That is known as multi-drug resistance, HR, H and R. So I will give the other alternative second line drugs. Because H and R is non-functional now, patient is not responding to them. So in the second line, no, XDR में patient is resistant to H and R, वो तो है ही है ना? Apart from that, patient is having resistance of one of the fluoroquinolones, that is fluoxacin, Oflox, Moxiflox, Levoflox. Second line का वो भी गया. And patient is resistant to one of the injectable of the second line. 3 injectable I taught you, no? They are kanamycin, amikacin, capromycin. So उसमें भी resistance है. So not तो we can give the first line drug, neither we can give first line and second line drug. So XDR resistance is a very bad prognosis, poor prognosis. You got my point? So what is the drug resistance in TB? Tell me. Now you can understand it well. The first is MDR, multiple drug resistance. And second is XDR, extensive drug resistance. What is the definition? Here patient have definition resistance for H and R. Here patient have resistance for H and R, but along with that patient have resistance for one of the fluoroquinolones, and patient have resistance of one of the injectable aminoglycoside, है ना? So either kanamycin, amikacin or capromycin. You got it? Can we go ahead? Okay, so that is the thing. So that is the thing. Let's go to the next question. What is the strain of varicella zoster vaccine? What is the strain of varicella zoster vaccine? Is it Nakayama? Is it Danish 1331? Is it Jarrell Lin? Or is it Oka? Okay, Oka. What is the correct answer? The correct answer is OKA, Oka. Strain of varicella zoster vaccine is OKA, Oka vaccine. Okay, you have to learn the strains of all the vaccines. In the morning, I taught you the vaccine. If you are attending and following me since morning, I taught you vaccine in detail. Who coined the term vaccine? Who coined the term vaccination? Who discovered the first vaccine? Who is the father of immunology? After that, I taught you the classification of vaccines. We divide the vaccine into 5 categories. You may be knowing the 5 categories. The live vaccines, which are attenuated, the killed vaccine, the toxoid, the polysaccharide, and the recombinant. And I told you the mnemonic to learn in each category. Okay, so it's time to perfect the vaccines again. Here I'm giving you a list of all the strains of the vaccine at one place. Please read the list. I'm not reading it. There is nothing to understand, but you get many questions. Yellow fever, the strain is 17D, very commonly asked PYQ. Varicella, the strain is OKA. Rubella, the strain is RA27/3. And what else? Mumps, Jarillin. These are frequently asked question, very frequently asked question. Here the question is on Oka. So please learn that. Please learn. BCG, Danish 1331. You cannot afford missing. These are the repeatedly asked question. The next question is in front of you. What is the disadvantage of case control study when compared to cohort? We have already seen the studies. Now you will tell me this answer. What is the disadvantage of case control study in compared to cohort study? Can you please tell me? Can you please tell me, is it easy to carry out? Is it a disadvantage or advantage? It is rapid and inexpensive. Is it advantage or disadvantage? I want to know the disadvantage of case control. I want to know the disadvantage of forward. I want to know the disadvantage of the backward study as compared to forward. Okay. It cannot measure cause to effect and useful in rare diseases. What is the correct answer? Yes. Cannot measure cause to effect. So it is effect to cause, not cause to effect, because it is backward study, right? So I already taught you the studies. Now, can I skip this portion, please? I've already explained you 2 times since morning. Yesterday also I taught you this. So you can make it out what are the advantages, disadvantages of each of the study. So I'm skipping this portion, right? You can read out what are the advantages, disadvantages. The next question we are coming is the lead time. Yesterday I taught you in screening of the diseases. What is lead time? What is lead time? Read the 4 option. What is the lead time? It is a time between what to what. It is a time between 2 things, what to what. What is the starting time? What is the end point? It is a time from early diagnosis to start of treatment, or it is a time from treatment to mortality, or it is a time from detection of disease through screening to its clinical symptom, or it is a time between the clinical symptom to complete treatment. What is the correct answer? You all are right. The correct answer is C. The correct answer is C. So yesterday I taught you the definition of the screening. Now see, this all complete population thinks they are healthy. They all are healthy. They all think they are healthy. But are they really healthy? So in the healthy population, actually in the complete population, 2 type of people are there. Some people are healthy and some people are diseased. The healthy population is divided into 2 categories, the real healthy and the apparently healthy. Real healthy are the one who have no disease, no sign, no symptom. So actually healthy. The apparently one have no sign, no symptom, but they have disease inside them. Very small disease. They are not presenting it right now, but they have the disease. In future, they will present when the disease will grow. So that is apparently healthy. So we perform a test known as screening test not on complete population. We perform it on healthy people. We perform screening test on healthy people, which differentiate the actually healthy from the apparently healthy. That is the meaning of the screening test, right? Now, when to perform the screening test? So what is the screening test? I told you it is different from the diagnostic test. So we perform diagnostic test in diseased person. Yes, absolutely right, Naveed. In the iceberg, we want to know the submerged portion, Naveed, है ना, right? The submerged portion. For the submerged portion, the vast submerged portion, we are performing screening test. The tip is visible, and for the tip, we are applying diagnostic test. The diagnostic test is for the diseased person, and screening test is for asymptomatic, apparently healthy people. You have to learn the examples of the screening test. There are many examples. You have to learn that. But you should be asking me a question, ma'am. There are many diseases, hundreds of diseases, thousands of diseases are there. Why don't we perform screening of all of them? And before the disease present, we should treat them. Why government is not doing so? We should be screened for gastric cancer, lung cancer, all the diseases. We cannot perform screening for all of them, because you have to perform screening on whom? We are performing screening test on whom? On whom? We are performing screening test on healthy people. How many healthy people are there in your country? You will say, ma'am, they are in billions. What is the population of India? Among them, most of the population is healthy now. You deduce the diseased one, but most of the population is healthy now. We cannot afford doing all the tests in billions of people. We cannot, no country can do so. Number one, this is the reason. Okay, so we will perform the screening test only for those diseases in which diagnosing early and treating early will significantly change the prognosis as compared to we are diagnosing and treating at usual course. तो सिग्निफिकेंट चेंज होगा तो ही हम एफर्ट करेंगे, खर्चा करेंगे, मेहनत करेंगे, टाइम लगाएंगे. तो दैट इज द रीजन. सो वी डू स्क्रीनिंग फॉर cervix cancer, breast cancer, oral cancer, HIV, diabetes, fetal anomalies, prostate cancer and colorectal cancer. So these are the few diseases, and apart from that few maybe more for which we actually do the screening. You got my point? So by screening, so you can see the complete thing. I want to tell you here, revise you two things: screening time, lead time. This is the disease start. Just suppose inside me a disease is starting, a small disease. So there is no test in the world. As soon as the disease is starting, it can detect it. No, it has to be grown a little bit. As soon as it is 0.000001 millimeter, a small nodule, it cannot be detected by any test in the world. Let it grow little bit, or let it cause some biochemical anomalies, then only it can be detected. This is the onset of the disease, and this is the first possible point where we can detect it. Okay, this is the first possible point where we can detect it. Okay, this is the usual course of the diagnosis. Now it will grow till now patient don't have symptom. Now it will grow. At this point patient will present, doctor, I'm having wrong in me, I'm having something wrong in me, some problem is there, you please diagnose and test. So this is the usual course. The patient will come to us. Here the patient have signs and symptoms are present here at this course. Here there is no signs and symptoms. Okay, so this time is lead time. Okay, and this is the final outcome. You will give the treatment. It can be good, it can be bad, depending at what stage the patient is presenting to us. Okay, especially in the cancers we are talking here, stage 1, 2, 3, 4. For 4 stage there is no cure. There is only palliative therapies available. It's metastasis. But for stage 1, 2, 3, earlier is the stage, better is the prognosis. We know it is a general rule for all cancers. Right, so especially we are talking for the cancers, the cervix cancer, the breast cancer, the prostate cancer, the oral cancer, the colorectal cancer. So screening is more useful in such diseases where the treatment stage wise matters. You got my point? Now if we want to diagnose it early, so कर क्या लेंगे? हमने diagnose कर लिया, चलो we have diagnosed the disease before patient come to us, we are going to the patient and diagnosing it. So उससे फायदा क्या है? We will treat it before the patient present. So it is very difficult to counsel a healthy person, apparently healthy person. The person feels that I am healthy. Imagine a lady, and I'm a gynecologist, I'm obstetrician. A lady is coming to me for contraceptive advice, just for contraceptive advice. She is a newly married couple, or she is on breastfeeding. She wants some advice on contraceptive. She wants IUCD insertion. So routinely I have performed just as a pap smear, as a screening. So I will do whatever she wants. I will give the contraceptive advice. I will insert the IUCD, whatever services are there, I will give that. But just routinely I have performed a pap smear, and on pap smear she is positive for cervix cancer, or SIN3 she is positive. So it's very difficult to convince she thinks she is healthy, but she is not actually healthy. She thinks because she don't have signs and symptoms. Now it's difficult that she is having a malignancy. First thing you have to convey this message: you have a malignancy, you have a cancer. Without symptom you have to get it operated, get your hysterectomy done, get the cervix out. Otherwise in future you will present it in the next few months, and at that time we are not sure at what stage you will present. Okay, so before you have symptoms, it's stage 1 still, or before stage 1 in SIN3 only, get it operated. Now will you think this a young lady, newly married lady, she will be convinced to do a hysterectomy? You will say, doctor, are you crazy? I don't have any symptoms, I don't have a sign, I don't have any bleeding, I don't have anything, and you are asking me to get operated. You are crazy. I will follow some other doctor, sorry. So that will be, so it convincing the patient is very difficult for screening test. And screening test ke liye they will be convinced, okay, do a pap smear. But once the results are positive, convincing them for confirming the diagnostic test and treatment, it will be a very difficult job, believe me, because they think they are healthy. They think just for the money is saying me all these things. The doctor wants to do a surgery, wants some money and like that. So that is their mentality. So convincing them is a really difficult job, in especially the cancers. So you have to convey the patient you have a cancer. Okay, believe the patient think, oh, my life is good, I'm healthy, and you tell no, you have a cancer. You don't have symptom for that, but I tell you that you have a cancer. So this is the thing. Anyways, so you diagnose it early and treat it early, so prognosis is very better as compared to patients present, and at that time you treat it. Treatment तो अभी भी करना है, बाद में भी करना है. Patient बाद में present करेगा तब भी treat करेंगे, और diagnose पहले करके अभी भी treat करेंगे. Ultimately we treat, but prognosis matters. So if we are treating it early, prognosis is much better as compared to the prognosis when we are treating at usual diagnosis. So this is the complete theory. You got my point? Okay, so that is the thing, hai na? So this is the lead time. Now in the lead time also there is a catch. So So you will be thinking this complete lead time is the such screening time. You can do screening at any point before usual diagnosis. No, in the initial part only you should do that. So because there is another point, the catch is that there is a critical point. You will say, ma'am, what is this critical point? The critical point is the point. Now, if you diagnose before this critical point in this section, if your diagnosis here in this section, then the prognosis will be different as compared to you are treating here after the usual diagnosis. But if you are diagnosing and treating here in the later part, it will be same as compared to this. So why to waste money, energy and then? So if you want to make a change in patient's life by changing the prognosis of the disease before disease presents, so you have to do it in the early portion of the lead time. So what is lead time? And this is known as screening time. You can see. So starting point of lead time and screening time is same. It is same. That is earliest possible point of detection. But the end point is different. For screening test, the end point is critical point. And for lead time, the end point is usual diagnosis. Got it? Got it. So you can see BC and BD. Starting point is B. So B is same for. So BC and BD. Say yes. Everyone say yes. Got it? So this is the thing. You want a change in the prognosis of the disease. Okay, if the patient is coming to you that doctor, I am having bleeding after sexual intercourse, it's a typical presentation of cervix cancer. The patient already presented. Now you have to check whether it is stage 2, 3, 4. Hannah, she is bleeding after sexual intercourse. She is having pain in sexual intercourse. She is a typical presenter of cervix cancer. You will examine, maybe there is a growth, or maybe she come with a cauliflower like growth on the cervix. So she is already late. Okay, so that is the usual diagnosis. Now you will operate, depends, you will give chemo, you will give radio, depending on many factors of prognosis, whether lymph nodes are involved or not involved, that prognosis is there. But if you are diagnosing it before the patient presents, no, it depends whether you are giving treatment here or here. So in the lead time, in the first portion, if you are diagnosing, that is in screening time, the prognosis really different, much better as compared to usual. But in the second half, if you are diagnosing and treating, it's almost same as that of usual. So better ki usual pe hone do, hum kahe ko itna mehnat kare. You got my point. So the diseases which is having a greater lead time, for them screening performance is good, like screening test can be performed, because greater is the lead time, we get a big zone in which we can diagnose as well as treat. We can do the diagnosis and we can do a screening test. But if the imagine lead time is very narrow, ab usme bhi aap first half itna sa lo, us time zone mein we have to screen also, confirm with diagnosis also, treat also. So it's very difficult to do so. So diagnostic screening test is possible only in those diseases where lead time is very big. So I have given you the examples of that list. Got it? So this is the definition of lead time. This is the definition of screening time. You got it. And I told you screening is most useful for the diseases which is having a long lead time. Say yes. Okay. Okay. Can we go ahead? Can we go ahead? Yes. So complete body checkup is a good way to do so. It is a good way to screen. Anyways, let's move ahead. What are the types of the screening? One more thing here I would like to add. There are two types of screening: prescriptive, prospective. What do you mean by prescriptive? What do you mean by prospective? Many MCQs come. Prescriptive is for own benefit and prospective for the benefit of the community, for other people. Let me give an example. Prescriptive screening for the people are screened for their own benefit. I screen a lady doing a pap smear. So if she is diagnosed, it's for her own benefit. She will be diagnosed early for cervix cancer, treated early. If I'm screening a lady for breast cancer, manual examination or mammography, it's for her own benefit. If I'm screening a male for digital rectal examination for prostate, it's for own benefit. But if I'm screening someone for HIV, it is not for the own benefit. Usko to ho gaya. Anna, we want to save the society. Okay, so I will take the sexual intercourse history. I want to know all the sexual contacts. By screening, HIV is highly confidential. You cannot disclose the name, not even to your close colleagues, doctors, others, friends. No, it is highly confidential. According to the ethics, you should not disclose the name of any HIV patient to anyone. You should consult them in personal, in one-to-one room in which no one other is there. And you should take them in confidence and take the complete sexual intercourse history. To all the sexual partners should be traced after that, and they should also be screened for the HIV, right? So this is for the benefit of the society we are doing, for the benefit of the community. So this screening is known as prospective screening. This one was prescriptive, this one is prospective. So there is a difference of one word. Here is E and here is O. Prescriptive, prospective. I hope you got it. Say yes if you got it. prescriptive, prospective, own benefit, others benefit. Here the best example is the screening, okay, among the sex workers. So you can consult, just suppose a prostitute is having some STD or the prostitute is having HIV. So asking the prostitute about all the clients is very important, and you have to trace all the clients of that prostitute. So that is for the benefit of the others. Hana, we are screening the prostitute for the benefit of others, not for her own benefit. Okay, that is the thing. Can we go ahead? Okay, the next question is in front of you. Fast. We have half more hour. I'm informed by the team that I have to end at 6:15 because I guess you have another lecture at 6:30 by Dr. Ashish sir, right, of physiology. So I guess you will have a break of 15 minutes and after that you can continue with physiology after my session. So I have to end at 6:15 anyway. So I will try my best to complete the 50. Read the next question. Okay. Read the next question. In a population of 5,000, the number of new cases of TB is 500. New cases is 500. Old cases in the same population is 150. These are the old cases. So what is the prevalence? How to calculate incidence and prevalence in a community? What is incidence and what is prevalence? You first tell me. Yesterday I taught you. These are the measures of morbidity of a disease. If you want to measure the morbidity of a disease, you have two indicators to measure the incidence and prevalence. For example, let's take an example of a disease, TB. I want to measure the morbidity of the TB in a community. Let's say the community is India. In a community that is India in 2022. So what is the morbidity of TB in India in 2022? That is my question. So what we can do? We can measure the incidence, we can measure the prevalence. There are two options. In incidence, the numerator is the new cases. Total new cases in 2022 from 1st January till 31st December, नए केस कितने diagnose हुए? That is the numerator. Denominator is total population or population at risk, whatever, mid-year population. But at risk, we will deduce the immune one. In the prevalence, we take total cases, current cases, new plus old, all cases. So whether the person is diagnosed in 2022 or before that, the old one also, I will include all the cases of TB. Denominator is same, it's population at risk. So you can see this is incidence, this is prevalence. In incidence, we take only new cases. In prevalence, we take new plus old, both cases. That is the first thing. The multiplier is also different. In incidence, the multiplier is 1000 or never 100. It can be 10,000 or 1 lakh also, but not 100. In prevalence, the multiplier is 100. So 100 multiplier means it's proportion. So P for P. Prevalence is proportion, but incidence, see the multiplier, it's 1000, so it's a rate. In both of them, the numerator is a part of denominator. Actually, the new cases as well as old cases are from population only. They are not aliens. So they are from the population only. The numerator is a part of denominator in both of them. But multiplier is different. That matters. So incidence is a rate and proportion. Prevalence is a proportion. Yesterday I taught you now. So apply the knowledge now. Just a second. Let me rub it. Can we apply the formula? What they are asking? They are asking incidence or prevalence? I guess they are asking prevalence in your question. So calculate it, please. Can you calculate it? What is prevalence? The formula is new case plus old case upon population at risk. Total population. So new case is given to you how much? New cases are given to you 500, old cases are 150, and total population is 5,000. Do the calculation. I'm not interested in doing that, but yeah, this is the approach. So yes, you all are right. Into 100, never forget. So 500 plus 150 upon 5,000 into 100. So answer will be 30%. So that's it. So coming on the next very important concept, है ना? अच्छा ये question आ गया. Next question. What is NRR? Net reproductive rate. What is correct answer? First you try, then I will let you know a very important concept here. I will tell you the difference between three things: NRR, GRR and TFR. Okay, what is the full form? Net reproductive rate, gross reproductive rate and total fertility rate. There are many MCQs on that, and I'm guarantee whosoever is watching me, hardly any person may be knowing the exact difference between them, but I will let you know. Okay, so please understand it. What is the correct answer? It is a number of girls born to a woman during her lifetime attaining the mortality. Okay, you all are right. If I change the question from net to gross, what is the answer now? What is the answer now? In that case, what would you like to change? Would you like to change the answer? Yes, you are absolutely right. Many students may be knowing that, but for the students who don't know, let me tell you. So I'm going to tell you four things: NRR, GRR, TFR and replacement level. Okay, imagine in India today, okay, in India today a girl is born, girl child, not boy, a girl child is born today in India. She is a newborn. She is born today only. She is newborn. So of course one day she will grow up, she will also have puberty, she will also have fertility one day, and she will get married, she will also have children, right? Of course, Hannah. So if she resides in India only, so we are expecting, it's not reality, we are expecting on the day a girl is born, we are expecting on that day only how many daughters she will have in future. Once she will grow up, she will get married, so she will also reproduce. How many daughters, how many girl child or daughters she will have in future if we apply current fertility indicators of India on her, and if we apply current mortality indicators of India on her. So fertility and mortality both I am applying on this newborn. So in future how many daughters she will have, so that is known as NRR. This is the meaning of NRR. This is the meaning of NRR, net reproduction rate. Ideally one girl should replace one girl in this world before she dies. Okay, so that's how the world continues. One is replacing one. The males cannot be pregnant, of course the females can pregnant, so a female should replace with another female before she dies, so she is replacing herself. Okay, so her daughter, she will replace herself. So every couple should have one daughter. Ideally it is ideal on an average. So if some couple is having two daughters, so some is having none, so ideal average should be one. So this is known as replacement level. We want NRR to be 1. So all the newborn girls, they are expected to have one daughter in the future if we apply current fertility and mortality on her. But currently for India, NRR is not 1, it's more than 1. We want to make it 1. The making it 1 is our goal. That is known as replacement level. That is the meaning of NRR. First let me know how many of you understood NRR. This is known as NRR. You got my point? Now the same I am repeating again. I am telling you what is GRR. What is GRR? For GRR, take again in India again. Today a girl is born. She is a newborn girl. Today she is born. So in future, we are again expecting, that's not reality. She can have 10 girls also. She can have 1 girl. She can have 0. We are expecting how many daughters she will have. Again, she will grow up. She will get married. She will reproduce. So how many daughters she will have in future if we apply current fertility indicators of India on her. So this is known as GRR. You may be thinking, ma'am, what is the difference? They are looking same. There is one difference. If you see very closely, I have made the difference. Here I am applying fertility and mortality both indicators. Here I am applying only fertility indicators, not mortality. That is the only difference between NRR and GRR. In both of them, we are expecting a newborn girl at some community, let's say India. She is expected how many daughters she will have in future if we apply what? If we apply current fertility and mortality of that country on her, or if we apply only fertility, no mortality on her. So this is NRR, this is GRR. Everyone give me a thumbs up. I lost your chat, give me a minute. Let me click on the link again. I guess I'm connected now. Okay, you got it? Purnima, you got it? Others, you got it? So this is the difference between NRR and GRR. Now, which is better according to you? According to you, which is better? NRR is a better indicator or GRR is the better? Of course, NRR is better, because here along with fertility, we are considering mortality also. Everyone has to die now. There is no one immortal in this world. Jo bhi is duniya mein aaya hai, sabko jana hai na? So there is no immortal, but here we are applying only fertility, not mortality. So NRR is better indicator as compared to GRR. You got it? So NRR is better. We want NRR to be 1. We want GRR to be 1. We want one girl should be replaced by 1. Ideally, we want NRR and GRR both 1. So this is NRR, with this is GRR. TFR is that only again. So take all 3 together. Take all 3 together. Again, we are talking about India, India, India. Today, a girl, newborn girl is born in India. Okay. Now, in future, she is expected, not reality. It is an expectation, expectation, expectation. How many daughters she will have in future? How many daughters she will have in future? And how many total children she will have in future? You got my point. Okay. So this is, here we are applying fertility and mortality, both indicators. Here also we are applying fertility, only fertility indicators, no mortality. Here also we are applying only fertility, no mortality. So I guess you got it. This one is NRR, this one is GRR, and this one is TFR. This is total family, na? Total family. So ideally total family is hum do, hamare do. Out of which we are saying one should be girl. So obviously other should be boy. So ideally every couple should have one girl, one boy. This is the ideal situation. One girl is replacing one and they are having 2 children. This is known as replacement. So ideally we want NRR to be 1. Ideally, we want GRR to be 1 and ideally we want TFR to be 2. This is the complete scenario. It is ideal. We are not ideal here in India. We want this, but we are not this. That is the point. Give me a thumbs up. I appreciate my efforts. So that is the thing. Okay, so please see here. You can see this is NRR, this is GRR, this is TFR. Let me define NRR. NRR is a newborn girl expected how many daughters she will have in future if we apply fertility and mortality both on her of that particular country. GRR, a newborn girl how many daughters she will have in future if we apply only fertility, no mortality. And TFR, a newborn girl, how many children, total children, son, daughters both, how many total children she is expected to have in future if we apply only fertility. So among them, we are applying mortality in only one of them, that is NRR. Okay, looking at this scenario, you understood NRR should be 1, GRR should be 1, but TFR should be 2. You got it? Now one more thing. Can I say TFR is double of NRR and GRR? Yes, of course it's 2, double of 1. Or can I say NRR is half of TFR, NRR and GRR? So learn their correlation. Very easy to learn. So can I say NRR or GRR is equal to half of TFR? That is their value is 1, that is half of 2. Half of 2 is 1. So please learn their formula. Student used to learn this formula. Why to learn? Common sense. Say yes. Right. And you got what is NRR? You got what is GRR, you got what is TFR, and what is replacement level? Replacement level is when NRR will become 1, we will say replacement level. Replacement level aa gaya. One girl is replacing 1. If we are applying fertility, mortality both. So this is known as replacement level. I hope you all got it. Yes. So read the definitions now. What is NRR? Now have a look on your question. I'm asking NRR. पहले बताओ NRR क्या है? What is NRR? It is a number of girls born to a woman during her lifetime. We are expecting the woman will have during her lifetime, assuming mortality. So we are taking fertility plus mortality both. So answer is D. But if I change the question to GRR, the gross one, okay, so answer will become C. It is the number of girls a woman will assuming having no mortality. We are assuming the woman is immortal, but there is no immortality, no? So that in that case, answer will become C. So please understand that. Okay. Okay, so this is the thing. So what is NRR? It's in front of you, number of daughters a newborn girl expected to have in her lifetime, assuming fertility and mortality both. Ideally, NRR should be 1. Ideally, it should be 1, right? So how many girls, this is a newborn girl, when she grow up, how many girls she is expected to have in future? That is, ideally one girl should replace one girl. This is NRR 1, the replacement level. Here we are considering mortality, that is a significant indicator. Okay, the next is the GRR. It's the same. It is the number of daughters a woman will have in her lifetime, assuming only fertility but no mortality. Okay, no mortality is highlighted. So GRR is same as that of NRR, except it ignores the life expectancy. It is ignoring the mortality. Got it? And what is TFR? It is the total number of children a woman is expected to have during her lifetime in the reproductive age group, assuming only fertility, not mortality. Okay, so that is the thing. It is also known as complete family size. Of course, TFR is complete family size. Okay, that is a complete family size. Ideally, one couple should have one son, one daughter. So each woman is replacing the one woman, that is NRR or GRR, and this is complete family size. Give me a thumbs up. Got it? So ideally, we want NRR to be 1, but currently NRR is not 1. And you learn this formula also. GRR or NRR is half of TFR. You got it or you didn't got it? GRR or NRR, we want them to be 1, and TFR we want 2. So half of 2 is 1. So please learn this formula. Now how to get NRR 1? We want replacement level. In India, we want replacement level. We want replacement level. We all want that. So for replacement level, we want NRR to be 1. But currently NRR is not 1, it's more than 1. One female is replacing more than 1. Maybe 1.2, 1.3, exact figure I don't know, I have to check, but it's more than 1. Definitely it's more than 1. So how to make it 1? You will say, ma'am, we have to reduce fertility, no? We have to reduce fertility. Then only it will be 1, because currently it's more than 1. So how to reduce fertility? Of course, with contraception. Of course, with contraception, we can reduce the fertility. There is only one way of reducing the fertility, is using contraception while sexual intercourse. Okay. So the most commonly 4 contraceptive methods are considered as standard. Let me tell you couple protection rate. For that, I want to tell you something. I want to explain you this line. If you want NRR 1, you have to make couple protection rate 60%. Then only NRR will become 1. If you want NRR 1, make couple protection rate 60%. For that, you have to understand what is couple protection rate. Okay, couple protection rate होता क्या है? उसके लिए एक दूसरी चीज समझनी पड़ेगी. What is eligible couple? है ना. Eligible couple क्या होता है? Who is the eligible couple? In every couple there is one husband, there is one wife. I mean there is a male, there is a female. So this is husband, this is wife. The male is fertile throughout its life. Till death the male can produce the sperm, but the female is fertile only till menopause. Okay, the reproductive age. Okay, so female is fertile from 15 to 45. Let's say for average 30-35 years. Maybe if you say 49, it's average 30-39. 30 to 35 years the fertility age is there. That is menarche to menopause. That is the reproductive age group. But the male from puberty till death, the male is always fertile, right? So eligible couple, the couple who can reproduce. Which couple can reproduce? In which the wife is in reproductive age group. If the wife is not in reproductive age group, the wife is more than 50, so that couple hardly can reproduce. That can't reproduce, I mean. So we have to provide the contraceptive services to the eligible couple, to target from all the couple, target only eligible couple. So let's, you know, narrow your zone so that to give the better services, है ना. So instead of targeting all the couples in the India, target eligible couple. Eligible couple is a couple in which the wife is in reproductive age group. The wife is in reproductive age group, that couple is known as eligible couple. Say yes. Okay, that couple is known as eligible couple. Now among all the eligible couple, जितने भी couple हैं इंडिया में, the all eligible couple, I mean to say the wife is in reproductive age group, how many of them are using contraception and doing the family planning? By family planning we mean whenever they want to expand their family, at that time they shouldn't use contraception. Whenever they do not want to expand their family, they should use contraception. That is planning. That is, they are doing planning for their family, whether they want to expand the family or whether they do not want, so that unplanned pregnancies shouldn't happen. Okay, so that is the meaning of family planning. So contraception, how many percent of them are using the contraception? Currently hardly 40% are also not using. So if 60% of the couple, not 100, if only 60% of the eligible couple will use the contraception, now job is done. Apna kaam ho jayega, NRR will become 1 at that point. So we want NRR 1. You want NRR to be 1? Of course, we want the population stable. For that, I've told you the demographic cycle now, 1, 2, 3, 4, 5. Currently, India is in stage 3. You want to enter 4. So for that, you have to reduce the fertility of the country. How to reduce that? Using contraception. So you want NRR to be 1. One girl replacing one girl before she dies. So it's a stable model of the population. You want NRR 1. So you have to make CPR, couple protection rate, to be 60%. When couple protection rate, the day couple protection rate become 50%, NRR automatically will become 1, and this is known as replacement level. Got it? So 60, not 100. We are saying only 60% of the couple, if they use the contraception during sexual intercourse, so NRR will become 1. Got it? Everyone give me a thumbs up if you got it. So this is the concept. So this is replacement level. So replacement level that I told you, right? So that's all about it. Okay. Okay, can we go ahead? So the next question is in front of you. Vaccine is what level of prevention? So the next question is on level of prevention. What is the level of prevention in vaccine? Yes? What is the correct answer? I'm waiting. So sex ratio is a different thing. Apratim. Don't correlate the two different things together. In the sex ratio, we want 1:1. The male and female should be equal. Okay, and here we are talking about the NRR to be 1. Okay, so NRR will become 1 if CRP is 60%. That is the replacement level. So first, reduce the fertility, make aware the people of the contraception. More and more couples, eligible couples, will use the contraception. One day couple protection rate will become 60%. At that day, after few years, automatically NRR will become 1, and gradually, not suddenly, it will take few more years, so that population will become stable. Okay. Okay, so yes, it is primary level of prevention. So yesterday I taught you the levels of the prevention. No, so we are giving vaccines before disease occur. Disease has not occurred. I am vaccinated for OPV. I don't have polio. That's why I don't have polio, because I am vaccinated. I am vaccinated for BCG. I don't have TB because I don't have TB because I am vaccinated. You know, so particular vaccine gives protection for particular disease. It is the thing, and we are giving the vaccine before the onset of the disease. So yesterday also I told you this is the normal life. This is the risk factor. Risk factor is the organism. Now in the air, Mycobacterium TB is also present. The virus, polio virus is also present. Diphtheria is also present. Pertussis, they all are present in the environment, in the air, in the water, in the soil. They are present. Now before they enter inside us and cause disease inside us, we want to get protected. You know, so if they enter inside human body, they cause disease. Initially early stage of disease, later on complications, late stage of disease, and finally disability is there. Now at what level you are intervening? You are intervening before the risk factor appears, it is primordial level of prevention. You are intervening after the risk factor is there but disease is not there, this is primary level of prevention. And you are intervening after the disease occur but still disease in early stage, not in late stage, so you are halting the disease at early stage. This is secondary level of prevention, and after late stage you are just doing the palliative therapy, that is tertiary. So currently in vaccine, the risk factor is present in the environment. Many students get confused between primordial and primary. Vaccine is primordial or primary. So please understand who is the risk factor here for vaccine. Risk factor are the organisms for which we are getting vaccine. What all vaccines you are vaccinated? You are vaccinated for DPT, OPV, BCG. So all these are present in our environment. In our environment, all these organisms. So risk factor is present, but we don't have disease. So at this stage we are intervening. So all vaccine are primary level of prevention. All. One more very frequent asked question in your exam: what is screening? Screening is primary level or secondary level? Just now before this question I taught you screening also, now. So screening is primary level or secondary level? Screening is primary or secondary? What is screening? Screening is performed on healthy population to rule out who is real healthy and who is apparently healthy. Apparently healthy are the people who think they are healthy but actually they are not healthy, they are diseased. So basically the disease is already started inside them, but it's very minute. They are not knowing there is disease, but disease is there. So you are intervening here at this stage. That's why screening comes under secondary. This is the reason. So all vaccines come under primary and all screening tests come under secondary. Who is asking this? Jobin, you are asking me to give the example of the primordial. The best example, there is a kid, there is a small school going kid. You ask the kid, Hana, don't smoke. Kid said, I don't smoke. Hana, I don't smoke. A dad is counseling the kid that you don't smoke. The kid will say, Papa, I don't smoke. So we are reinforcing the thought. The smoking is absent. Smoking leads to lung cancer, everyone knows. So person don't smoke, and before he smokes, you are reinforcing the thought. You are discouraging that I know you don't smoke, but in future also you don't smoke. So that is the best example I can give. Before the risk factor appears, you are tearing it off. So that is a primordial. You got it? Jobin, can we go ahead? Okay. So this is the thing. So please learn that. Coming on the next question. What is true about double-blind trial? What is true about double-blind trial? What is blinding? Double blinding, single blinding, triple blinding. There are three types of blinding. Who is blinded here? Patient is blinded. Patient does not know. Okay, let me tell you the blinding. I will come on the question again. Let me tell you what is blinding. Okay, so for understanding blinding, you have to understand the bias. Anna, we are doing epidemiological studies. I told you many types of studies. First we do descriptive study, then we do analytic study. In the analytic study, we do case control and cohort study. After that, we do the experimental study. In experimental study, we do RCT, that is randomized control trial, right or not? So we do not want mistakes in that. The bias are the errors, the mistakes or errors. That is known as bias. So we do not want mistakes now. For removing it, we will do blinding and randomization. Randomization, I already taught you yesterday. If you have watched my yesterday's session, I told you what is randomization. So we put the patients in one of the two categories, the test group and the control group. But we do not disclose to the patient in which group you are. It's a lottery system. So the test group will get the real drug and the control group will get the placebo. So by doing so, we are removing the selection bias so that like can be compared with like. So that is randomization. But what is blinding? What is blinding? Let me tell you blinding. Okay, there are three things. The subject means the patient, and there is the investigator, and the third person is the analyzer. Subject, investigator and analyzer. Let me show you the diagram. Can you see? This is these are the two volunteers. Okay, these are the two volunteers in a clinical trial. In a clinical trial, experimental trial. Now one of them is getting the real drug, the test drug, and one of them is getting the placebo, right? The patient don't know he's taking what. The patient know I'm taking a drug, but red capsule, red. So there are two patients sitting together. She's saying I am also having red capsule, you are also having red capsule. Now which is having the real drug, which is having the placebo? We don't know. External appearance is same. So who is blinded here? The patient is blinded. The patient is blinded. So that psychological impact, psychological errors are not occurring. For example, to this patient you tell that you are taking a real drug, the test drug we are giving, and to this patient you told we are giving placebo to them. So after taking the drug, she will say, yeah doctor, I'm feeling better, yes, and she will say, no, I'm not feeling better, right? So maybe psychological they are feeling so, but we want the real results. We do not want psychological impact on that. So for removing errors, we are blinding the patient. right? But the person who is distributing the drugs to them, after distributing drugs, what this person will do? What this person, he will ask the effect and side effect in this, how you are feeling, good or bad, what are the effects, what are the, and effect and side effect here also. But this person knows that who get the placebo, who get the real drug. So we have blinded only patient, not the investigator. He's the investigator, we have not blinded him. So what he will do, so this is single blinding. In single blinding, only patient is blinded, but not the person who is giving the drug and taking the history after giving the drug. After giving the drug, he take the proper history also, like how you are feeling, we have given you a drug, are you feeling good, are you feeling bad, do you have any side effects, and he measures, like we are giving any antihypertensive, so yesterday's BP, today's, so he will do all the investigation to this patient also, to this patient also. So this is single blinding. You will say in single blinding the patient is biased, the subjects are blinded. Okay, so we are removing subject bias, the psychological impact is removed here. Now both of them don't know now which drug they are getting, so they will give you real experiences, how they are feeling, not psychological experiences. Okay, but here this can do some mistakes, like this person know this is placebo patient na, so usko zyada time nahi dega, हाँ कैसा लग रहा है, हाँ ठीक लग रहा है ना, हाँ ठीक है, because he know this is the placebo group, so he will not waste his time in the placebo groups and he will take a detailed and dedicated examination of the test group. उसको अच्छे से अच्छा लग रहा है, नहीं लगना तो चाहिए तुम्हें, अच्छा लग रहा है क्या, वैसा है ना. So this can do the mistake. So the second thing, we can blind him also, है ना. So patient also don't know which drug the patient is getting, the investigator also don't know which drug he is giving to this and this. Okay, who knows? The boss of the study, the head of the study, the epidemiologist who is performing all the study, right? So this is double blinding. In double blinding, we are removing the subject bias as well as investigator bias, right? Now who is the third person? This is the patient who is getting the drug. Okay, this is the investigator who is giving the drug to him. So first we have blinded only patient, single blinding. The double blinding, we have blinded the investigator also, the person who is doing the calculation, iska effect, iska side effect, iska effect, iska side effect, calculation, ABCD wala table, we will formulate a 2 by 2 table now. So this person can do the mistakes in that, like he will do better results, he wants some better results in this. Just suppose he want to prove the drug is good, so he will give some better results there, he will do manipulations there कि नहीं यहाँ पे थोड़ा अच्छा कर देते हैं, वहाँ थोड़ा बुरा दिखा देते हैं, so results will think that drug is very good, effective. He can do some changes in the result, he can do some manipulations. Blind him also, उसको भी मत बताओ कौन क्या है. Who knows everything? The head of the study, the main epidemiologist. So this is triple blinding. So best is the triple blinding. Say yes, give me a thumbs up if you got it. What is blinding? So in blinding, what we are doing? Single blinding, only subject is blinded, the patients are blinded, they don't know which drug they are getting. Double, along with the subject, investigator is also blinded. Triple, along with the subject, along with the investigator, analyzer is also blinded. Are you people there? Give me a thumbs up. Come on, got it? So that is the blinding. Now have a look on your question and tell me the answer. What is true about blinding? Yes, patients getting double treatment. Double blinding का मतलब क्या है? Patient getting double treatment. Patient does not know that he is a part of trial. Patient is getting both placebo and medicine, or patient does not know what he is getting. So of course the correct answer here is D. You got it? That is the meaning of the blinding, the 3 types of the blinding. Okay, the next and the last question I guess I am discussing here, and after that I have to end the session. In iceberg phenomenon, what the submerged portion represent? You already know that, I guess. The submerged portion represent what? In iceberg phenomenon, do you know what is iceberg? So we are comparing the diseases with iceberg. Have you seen an iceberg? In the iceberg, hardly you can see any tip outside, and most of the portion of the iceberg is submerged inside the water. You cannot see that. You cannot see that like this. You cannot see that, the submerged portion. So you will say, ma'am, iceberg यहाँ कहाँ से आ गया PSM में? ठीक है, देखा है iceberg, but यहाँ कहाँ से आ गया? So what is the problem here? Why we are comparing? To whom we are comparing with the iceberg? We are comparing the iceberg with all the diseases in the community. We are comparing it with the iceberg, all the diseases in the community. So whatever we are seeing ना, जो patient हमारे पास आते हैं, doctor, I'm having some problem in me, I'm ill, I'm diseased, treat me, diagnose me. That is the tip. A small portion we are looking. So the person who have the symptoms, the person who have signs, the person who have clinical features, it is the tip. It's very small. But a vast majority of the patient, they feel they are healthy, but actually they are not healthy. They are apparently healthy. So they are invisible in the community. They are among us who feel so we are healthy. Maybe I'm having some disease inside me. I feel I am healthy. I don't have any symptom, but maybe I'm the submerged portion of this. Okay, maybe you are the submerged portion, right? So this indicate the asymptomatic cases. The preclinical, subclinical cases, I mean, they indicate the carrier. Okay, and this portion is very big, right? Now it's very easy to treat with the tip, because tip तो हमारे पास भागती हुई खुद आएगी, है ना? खुद आएंगे, डॉक्टर मुझे प्रॉब्लम है, ठीक करो, है ना? So they will come to the physician by themselves. We apply a diagnostic test on them, we treat them. It's very easy to deal with the tip, but the difficult portion to treat and get diagnosed first, this portion, the submerged, because they are healthy now. How we come to know that they are diseased? The disease is very small inside them. So for them, we don't apply diagnostic test, we perform screening test on them. So diagnostic test is performed on the tip, screening test is performed on the submerged portion. The tip is representing the clinical cases, the submerged portion is representing the subclinical case, latent case, hidden case, carrier, whatever you say, they are asymptomatic cases. So we have to perform screening test on them. So what a physician see in the community is the tip, and what an epidemiologist see in the community. Epidemiologist is interested in the submerged portion. So I hope you got it. Say yes. So epidemiologist, so clinician is the doctor. We are interested in treating. कि patient आए हम treat करें. ठीक है. You are interested in the tip, but tip is very small, only 5%. 95% is the hidden portion. So epidemiologist perform a screening test for that. The screening test is performed for the hidden portion, and diagnostic test is performed for the tip. Now have a look and tell me the answer. In iceberg phenomenon, the submerged portion represent what? The submerged portion represent undiagnosed cases of the community, diagnosed cases of the community, clinical cases what the physicians see, clinical case what the investigators see. So submerged portion is undiagnosed case. Here wrong answer is take, my mistake, I agree. Correct answer is E, I am correcting. Okay, so correct answer is A. B, C, D are wrong. Okay, because B, C, D are diagnosed clinical cases, they are the tip, and the submerged portion is the A. And D is not the answer. Why Yash, why you are saying D as the answer? Am I doing some mistake? Why in iceberg phenomenon the submerged portion represent? No. Undiagnosed cases in the community will be the answer. The correct answer here is A. The correct answer is A, not D. I guess you are confused. Okay, so that is the thing. Okay, so I shall stop now because you are having another session. Now I can continue. 2-3 questions are left. You can read it from the PDF. I will share the PDF and give me a minute. So you want to say something? Your concepts are cleared? Any doubt? Give me a feedback. How was the session? You learned? So today we discussed 50 topics. I mean 47 topics, not the questions. I know. So thank you so much for being with me. Thank you for giving your precious time to me. The students who have joined me today only and not joined me yesterday. So yesterday I took a complete marathon rapid revision of the PSM in 2 parts, part 1, part 2. That is available on this YouTube channel only where you are watching. That is NLC YouTube channel. I request them to watch the rapid revision of entire PSM part 1, part 2. It is total 8-hour revision in which there is a compact revision of entire PSM. And after that, today 8 hour we have discussed the 50 topics. So please watch 8 plus 8 total 15-16 hours are there. If you watch this 15-16 hours, most important topics of entire PSM are covered here for your competitive exams. So please watch the both. Here also today's test is also in 2 parts, part 1, part 2. So total 4 videos are there on this YouTube channel. 2 of yesterday, the rapid revision part 1, part 2, and 2 of today, the test and discussion part 1, part 2. So please share the links with all the medicos, with all your friends, colleagues, everyone. Don't forget to give your feedback after ending the session in the comment section. And that's it. Thank you so much. Wishing you all the best. I wish luck to you and get selected whatever exam you are targeting. Study hard and hope to see you again. If you have any doubt, you can get back to me. I will try to solve it as soon as possible. And that's it. Hope to see you again. Bye-bye. I'm ending this. After that, I guess you are having a physiology session by the sir, Dr. Ashish sir. They will take, and please continue there. Thank you. Bye-bye. Good night.